All right, we should be good to go here. Again, today's topic will be the chapter in the DSM titled The Eating and Feeding Disorders. For each aspect of the chapter that we reviewed today through our PowerPoint slides, I'll just throw up a brief set of objectives. For this first slide set, learners should be able to define anorexia nervosa as well as bulimia nervosa. They should appreciate the subtypes of anorexia and list 3 signs of the refeeding syndrome. Some general points with regard to the chapter itself. These conditions are among the most complex conditions in all of psychiatry, quite frankly, in all of medicine. And that complexity boils over and presents as a disturbance of eating or eating-related behavior. One of the things that I think clinicians must understand that these conditions manifest or come to clinical attention through behaviors related to eating. They have little to do with actual eating itself. So in a way, the title of an eating disorder is a bit of a misnomer. Eating is the vehicle by way these conditions manifest in clinical practice. So we have to really keep that in the back of our minds. And for purposes of this film, certainly to the extent that we use this film, Hocus Pocus, as a fictional case study, we'll get to some of those complexities. The manifestation is usually through an altered consumption or absorption of food. And like any mental disorder, all of the above must result in clinically significant distress or impairment. The word disorder, as the top of the slide reads, always operationalizes as clinically significant distress or impairment. If your particular client, consumer, patient presents textbook to you with what appears to be an eating or feeding disorder, or an anxiety disorder, or a depressive disorder, they check every box with regard to what the textbook definition is. If those behaviors, if those signs and symptoms do not result in clinically significant distress or impairment, you cannot diagnose them with having a disorder, right? So that's very important to understand moving forward. And that applies to almost every single mental disorder described in the American Psychiatric Association's publication of the DSM, that is the DSM-5. There are 2 exceptions to this rule, right? So even though we are not talking about these illnesses today, that is, they're not part of our seminar on this date, I should mention those 2 exceptions. Individuals who have dementia, who suffer from Alzheimer's disease, actually have very specific signs and symptoms that allow for the diagnosis of what is now referred to as major neurocognitive disorder, formerly known as dementia. If that patient's monozygotic twin, if their identical twin presents with the same exact signs and symptoms, but those signs and symptoms for them do not impair functioning, the title or the label of that condition is called mild neurocognitive disorder. That is, mild neurocognitive disorder differs from major neurocognitive disorder in that mild does not impair functioning. Otherwise, the signs and the symptoms could be exactly the same. So that's one exception to the rule, mild neurocognitive disorder. The second exception to this rule is a condition called hypomania. Hypomania has the same exact signs and symptoms as mania. So individuals have this elevated mood and related symptoms. So they look as if they're high on a stimulant, but their behavior is not substance induced. So there's rapid speech, flight of ideas, impulsivity, etc. That's mania. When that same constellation of symptoms manifests absent clinically significant distress or impairment, we call that hypomania. So hypomania and mild neurocognitive disorder are the exceptions to the rule. They're really not disorder. Matter of fact, mild neurocognitive disorder is a misnomer. The APA should have not attached the D word to that diagnostic label. They should have just named it mild neurocognition deficit, perhaps. Nonetheless, for our purposes today, the eating and feeding disorders will result in clinically significant distress or impairment by definition. And here's your list of what the new categorization of the eating and feeding disorders are. I tried to piggyback this with the movie Hocus Pocus, which of course, even as the title indicates, conjures magic, right? So the movie is about three witches, and these Sanderson sisters conjure magic. And if you remember that from the movie and think of abracadabra, the word cadabra serves as a makeshift acronym to remember the actual listing of the eating and feeding disorders. So the first one, you're gonna have to give to me. It was difficult to actually find an acronym to help us remember those specific eating and feeding disorders. So the first one, pica, actually goes by the last two letters, the C and the A, spelling out the word cadabra. Otherwise, there is the disorder of binge eating. There is avoidant/restrictive food intake disorder. There's bulimia nervosa, rumination disorder, and then finally anorexia nervosa. Now, the order in which we're going to go through this list is going to jump around a bit. That is, I'm not going to comply with the order of the acronym, but the acronym does serve to remember or recall the different individual eating and feeding disorders, the first of which, pica. Pica, as most of us understand, is the persistent eating of non-nutritive or non-food substances. Now, if someone puts or ingests something, it is not automatically pica. Pica is a behavior. And by definition, the American Psychiatric Association defines behavior as lasting 1 month or more. So if what is observed operates in a vacuum, it's a one and done. We do not diagnose somebody as being mentally ill, right? It's an event, it's a circumstance, but it's not a mental illness. When it's persistent, then it becomes troublesome and perhaps is a mental illness or a mental disorder, and persistence here equals 1 month. Also, we have to make sure that even if it persists for 1 month, we are dealing with this behavior at an inappropriate developmental level. A child would be expected to always put things in their mouth. In that way, if a child continues to put things in their mouth and ingest things, a toddler, a 2-year-old, they should not be diagnosed with a mental disorder. They should not be diagnosed with pica. That is, pica by definition must be inappropriate to the developmental level. And it also must not be part of a culturally sanctioned behavior either, because if it is not a mental disorder. And that's something that is that fourth bullet is something that is a common thread throughout the entire DSM-5, whether we call the condition pica, schizophrenia, etc. The American Psychiatric Association, in their latest revision, was very careful to include that fourth bullet in the definition of almost every single mental disorder now defined. That is, if the behavior is culturally sanctioned, if it is a culturally supported or normative practice, it is not called a mental disorder. And the fictional twist here is that we're focusing on a culture in Hocus Pocus that is separate from most of ours. Now, if there are any witches or Wiccans in the audience, I want to be culturally sensitive and have diversity and inclusion, but in the absence of there being any witches in the audience. The practice that we are going to see in Hocus Pocus is part of a separate culture or subculture, and therefore, if there is anything going on that might resemble pica, we'd have to be very careful to avoid social stigma and diagnose that subculture with a mental disorder. And of course, what I'm referring to is the brew they make. As we're looking at the scene where they conjure through making a brew, I think most of us who are not witches or Wiccans would think that that would be abnormal, and maybe to the extent that they would eat the different things that are in that brew, maybe afflicted with pica. So at the very least, the scene in Hocus Pocus where they conjure through a brew could certainly lead us to a discussion of pica, but probably falls short of allowing us to actually diagnose pica, in that we have to respect the cultural norm established by witchcraft. The next disorder I want to introduce and discuss in the eating and feeding disorders chapter is anorexia nervosa. For our purposes today, I'll just refer to this as anorexia. For full disclosure, in medical jargon, when we mention the clinical term anorexia, it just simply means lack of eating. So individuals who have wasting syndromes, end-stage cancer, end-stage AIDS, may have anorexia. That's different than the mental disorder titled anorexia nervosa, right? So with that disclosure, for today's purposes, I will refer back to this mental disorder simply as anorexia. Here is some obligatory demographic data. Individuals suffer from this illness at a less than 1% prevalence, right? So a rare disorder. However, I think that I should also mention that this disorder very likely goes under or undiagnosed, right? So as far as the published data are concerned, 0.4%, less than 0.5%. There is a significant male to female ratio of 10 to 1. It is more common in industrialized countries and certainly has even higher prevalence among professions that require thinness. This condition commonly begins in adolescence or young adulthood. Again, I think the time to onset is skewed. That is, the disorder itself likely begins even earlier and becomes manifest or discovered during adolescence. It is often associated with a stressful life event. The crude mortality is about 5% per decade, and the suicide rate 12 per 100,000. What you're looking at here is the actual DSM criteria, and I think this is one of the more important slides we have to discuss. Eating disorders in clinical practice are very often difficult to diagnose. As I said before, these conditions often go undiagnosed, and when they are diagnosed, diagnosis is usually delayed several years. And we'll get into some of the complexities as to why that occurs. But I think one of the primary reasons is in seminars such as this, it is often confusing how one would go about defining this condition. If you ask medical students the definition of anorexia, a lot of them struggle and don't fully understand the definition, and certainly don't understand how that definition maybe differentiates from other disorders of feeding and eating. So I really think this acronym is one of the better ones that I've come up with. It does link back to a film back in 1989 titled Tango and Cash. So the unfortunate nature of this is, despite my really enjoying this movie back in 1989, it is not all that great of a movie. So Kurt Russell is awesome. In the 80s, Sylvester Stallone was awesome. Together, this movie was typical 80s. But even with that, I have the humility of understanding that when I assign this movie, hypothetically, to, let's say, my medical students, they're not going to come into work the next day prepared to discuss this film with a smile on their face. And I totally get that. On the other hand, there is a scene from this movie that created the neologism, that is the new word FUBAR, F-U-B-A-R. I'll leave it up to you to, and you could very simply, and I've just checked into this and confirmed this, you could very easily find that single scene on YouTube. I would definitely recommend people access that scene and watch it during one of our breaks. But I would fall short of recommending this film in its entirety. FUBAR, taken from that scene, stands for effed up beyond all recognition. And I think there's relevance to that as well, which I'm going to get to in just a little bit. For now, I want us to take those very letters, and I want to divert your attention to the left side of the screen, where that same word with those same initial letters spell out the actual DSM criteria. And it does so in almost, I think, the perfect order as well. That is, if we discuss anorexia nervosa, it is absolutely important and critical to understand that this condition, first and foremost, is defined through a fear of gaining weight despite being underweight. Okay, a fear of gaining weight despite being underweight. And you can make that one full sentence, and if you're able to do that and remember that sentence, you've gone 90% of the way of defining and understanding what anorexia is. It is a fear of gaining weight despite being underweight. Now, I don't want to get too ahead of ourselves, but the direct opposite begins to define bulimia, right? So not only does the FU in FUBAR allow us to remember the most critical part of the definition of anorexia, but it also allows us to remember that part of the definition that differentiates from the other eating disorder that a lot of learners, a lot of professionals confuse with anorexia, and that is bulimia. The next item, the next criterion, body image disturbance, is one that is shared with bulimia, right? So we go from the first two parts of the definition, a fear of gaining weight despite being underweight, now to the third clinical criterion of body image disturbance. And it's very important to understand that not only is this the criterion that is shared with the definition of bulimia, but it begins to really get at what the core of eating disorders is all about. Because in both cases of anorexia and bulimia, individuals struggle with their body image. And the DSM-5 had considered, and for some unknown reason, decided not to rename this chapter the body image disorders, because that's exactly what these eating and feeding disorders truly are. They are body image disorders. And as soon as you understand that, by remembering perhaps the third part of FUBAR, you'll go a long way to understanding what motivates that aberrant eating behavior. And then finally, again, I think this fits perfectly in the acronym. The last thing to consider as part of the definition of the condition of anorexia is that there are two subtypes: restricting versus binge eating, right? So that's the R in the acronym FUBAR. I did skip one of these, and I skipped it for a purpose, because we're going to discuss amenorrhea now. I think it's important to remember amenorrhea, but it's also important to remember that one does not necessarily have to have amenorrhea to define or to rule in anorexia. And that was a decision made in 2013 with the publication of the latest revision of the DSM-5. Now, amenorrhea is the loss of one's menstrual cycle, right? So, for instance, there is primary amenorrhea, and that is when an individual does not have their first period. That's primary amenorrhea. They never had a menses. On the other hand, there's secondary amenorrhea. That is the loss of one's period in someone who has been having menses or has been menstruating. The most common cause of secondary amenorrhea is pregnancy, right? So an individual may stop having their period and upon getting a pregnancy test, then understand why they have secondary amenorrhea. Right? Because the onset of this condition is usually at or around the age of adolescence, primary amenorrhea is a very, very common clinical finding. The reason why the American Psychiatric Association removed it from its definition, and again, to rule in for anorexia, the individual would need every single one of FUBAR. And the exception now is amenorrhea. So although a clinical finding, it is no longer required. And the reason why is because we have found that individuals may in fact rule in for fear, for underweight, for body image disturbance, and for one of those subtypes, but don't have amenorrhea and go on to actually develop anorexia. So if amenorrhea were kept in the definition, what would happen is that you would fail to diagnose an individual who in fact does have anorexia. And that's called a false negative, right? The failure to pick up on something that is truly there is called a false negative. And you can then just consider the potential morbidity and perhaps even mortality of missing that diagnosis. So that was one of the reasons why the American Psychiatric Association took amenorrhea out as a required criterion. The other reason why is that, as I mentioned before, this condition, when it is discovered late. And one of the reasons why is because this condition would often be discovered through primary pediatric practices when parents would take their daughters to the doctor because of primary amenorrhea. If that primary amenorrhea, that is, their daughter never got her first period, we could, I think, safely assume that this condition, or one of the potential causes of this being anorexia, had been persisting for years, but now is being picked up late only because of the criterion of amenorrhea, that is why the individual may have been taken to the physician by their parents. So premenarchal demographic group certainly now is having this condition diagnosed more because of the removal of amenorrhea from the diagnostic criterion. If you take medications that stop your period, that could confuse things because the way hormones work, you could either continue to have periods when, for instance, anorexia may stop them and vice versa. So the use of contraceptives and how that might impact hormones and how that might impact one's menstrual cycle confuse the issue, remove amenorrhea from the diagnostic list, and you solve that confusion. That holds similar for postmenopausal females. Very similar logic with regard to the impact, in this case, of menopause on hormones. And then finally, males. If you're waiting for a male to have their period stopped in order to diagnose, excuse me, I almost said amenorrhea, in order to diagnose anorexia, you're never going to diagnose anorexia in males. And it was discovered that there were a significant number of males struggling with anorexia who just went misdiagnosed because of that clinical criteria. So these are all the reasons why the American Psychiatric Association removed amenorrhea from that symptom list. Once you diagnose anorexia, the next step is to look at the potential subtype, because Treatment planning is actually contingent upon which subtype the individual is struggling with. And the first one we'll look at is the restricting subtype, primarily because it fits the actual definition, that is the acronym FUBAR. Individuals with restricting subtype often have personality traits consistent with being submissive and dependent. Individuals with this subtype often have difficulty separating from their parents. They are preoccupied with being perfect, with being in control, and with orderliness. That is, they have traits consistent with obsessive compulsive personality disorder. This subtype can only be diagnosed if and when the individual is not binge eating or purging, right? If the individual is binge eating or purging, that will take precedent. This particular subtype, binge eating and purging, is exactly what it sounds like. Individuals are prone to discrete episodes of binge eating, followed by discrete episodes of purging or vomiting. The binge eating or purging subtype is more common than the restricting subtype. This condition is hallmarked by impulsivity, and along those lines is consistent with a group or cluster of personality disorders that are usually defined through impulsive acts. What I'm referring to there is the cluster B personality, as well as related conditions, including substance use disorder, and then even episodes of suicide, self-mutilation, and even stealing. Right? So impulsivity is the hallmark of binge eating and purging subtype. And this is just a review slide with regard to the definition of restricting versus binge eating and purging. Again, if your patient, if your client consumer is demonstrating both aspects, the single best diagnosis, the most likely diagnosis will be the binge eating and purging subtype. That will actually take precedent. That is more common. In either case, individuals are likely to present with ritualistic eating. Now, again, I kind of took advantage of the words here with regard to rituals pertaining to eating, because it, again, I think links directly back to not only Hocus Pocus, but the three Sanderson sisters in conjuring through their brew. Right? So again, the play on words with ritual. However, it's important to consider that ritualistic eating is often manifest. Now, this is important for the individual's social support system, primarily their parents. Parents may not understand that the individual is, that is their daughter or son, is struggling with anorexia. However, they may observe ritualistic eating. This includes, number one, observing or directly observing eating habits, separating peas, eating peas one by one, separating different color foods on their plate, things that might be observed. On the other hand, another variant of rituals when eating would include eating in secret, right? So individuals might actually, and very often, binge when their parents aren't around. So the binge eating and purging behavior is not something often that we see as demonstrated on TV. I'm now thinking of a Seinfeld episode when George Costanza's girlfriend at a restaurant, upon finishing her meal, very quickly excuses herself to go into the bathroom. And fairly quickly, George, one of the core characters in the situational comedy, begins to think that she has been binge eating and now in that public bathroom is purging, right? So these behaviors often occur in secret, and if and when they don't, and they are observed, we can see rituals as well as usually reported by the parents. Largely due to multiple factors. One, of course, being binge eating and purging behavior, and that kind of piggybacked by the fact that this condition usually goes undiagnosed. It goes unrecognized by primary caregivers and therefore undiagnosed in the medical setting. Medical complications are much more prevalent in anorexia when compared to other mental disorders. So, people with bipolar disorder, schizophrenia absolutely have medical complications as a result of their mental disorder. However, I think if you ranked the mental disorders according to the extent of medical complications, anorexia probably ranks number one overall. This slide, I'm not going to go into with any real detail. I think the one thing that learners, that the audience should really pull from this slide is that anorexia nervosa is a multi-system disease. And it really does hit almost every system. So when you see an individual in practice that appears to have multi-system disease at a young age, the clinician must consider an eating disorder in general and anorexia in particular. And again, you can again see this is a great example of how and why this very condition often goes undiagnosed. And that's because if you're waiting for this condition to result in these medical complications, which of course takes time, and you only think back retroactively when you see someone who at a young age, a young adult, a late teen with GI, cardiac and pulmonary complications, and then think that they may have anorexia, think how many years you've lost with regard to the onset of that eating behavior. Okay, so I'm going to stop sharing my screen just for a sec because the next condition of bulimia is something that I will compare and contrast to anorexia, but it really would not be worth doing this or really of any high yield doing this if I didn't pause and ask the audience if they have any questions at this time pertaining to anorexia. So anything we discussed about this condition, anorexia nervosa, that you have questions about or would like to discuss further. Well, it's good news. Having said that, I know we didn't assign anything. We never do. And I know that Black Swan is not a film that we're actually going to watch today. I do want to bring this film up to really kind of tie up any remaining loose ends pertaining to anorexia, because I believe Black Swan is among the best, if not the best, film made to depict this condition, again, specifically anorexia. So for those of you who either know about or perhaps even watched Darren Aronofsky's Black Swan, I want to talk about the character of Nina, right? For those who may have seen this movie, and hopefully maybe have seen it recently, any behaviors of Nina that as a clinician would concern or interest you?
I think simply looking at her is disturbing. I mean, there's this graphic, image of her shoulder blades and her clavicle, which is so disturbing. And I think the compulsivity, where she's just driven to distraction, really. It's a disturbing film, but good.
I completely agree on both levels. So let's hypothetically take Nina, and in that scene, have that scene set in a physician's office. Could you see how a physician would then ask Nina if her appetite's fine, if she's eating okay? Are you eating? I think at a normal level, meaning that you're not getting into any kind of analytic mode, when you see someone that thin, remember, the condition of anorexia is defined by being underweight. But there are plenty of reasons why people are underweight. And in this particular movie, Nina is a ballerina. But I could see a physician asking, are you eating enough? When that character says, yeah, what to do next? Because if the answer is nothing, because reliably, that's how people talk to each other. You inquire, they give you an answer, and if their answer is deemed reliable, that conversation probably doesn't have much any more legs. Thoughts?
So if I may, if you don't mind, so my experience at work, and I work in a PhD, a PHP and IOP program, is a lot of the primary carers, if they have a patient who comes in like that and they're overly exercising because of sports or because they want to be in the Olympics or whatever it may be, will tell them that they just need to add the calories. And a lot of times they will not even think of referring to an eating disorder program until something happens. They faint, they end up in an ER. So, I mean, not that all primary cares don't pick it up, but I'm noticing that a lot do not, or don't say anything about it. And also because a lot of the parents have eating disorders, mom, dad. So I just wanted to make that comment.
I completely agree. I absolutely 110% agree. And, you know, this also brings up another problem that I think complicates all of this. And that is, if there's a clinician that is concerned, now you have to rely on collaboration, for instance, with a primary care office. And, you know, the concern there is that the patient will only get as much help as that proverbial weakest link. That is, if there's one person, if there's one entity that is part of that multidisciplinary treatment team that falls short, that unfortunately is going to be the end result, or likely to be the end result with regard to this comprehensive treatment plan.
Right.
I
mean, fortunately, where I work for adolescent medicine over at Overlook. So we have the whole package there. So they usually hand over the gavel and we take over. So, and sometimes they don't want them back. So that's kind of how that goes, but.
Can I just ask you a question? Are there centers still remaining that are really viable, like Renfrew Center or inpatient treatment that you're aware of today for eating disorders?
Yeah, there are a lot of them.
Okay.
It's just that you have to go, and depending on the age, and depending on what kind of treatment you're looking for, because there are many different types of treatment, from traditional to family-based therapy. A lot of times you have to travel across country. It's not, the Northeast is not the best to look at the load of institutions. It seems like, you know, out West is better. Laureate, in my opinion, is the best, and that's in Tulsa, Oklahoma. But you have to be a girl, and you have to be by birth, and you have to be 15 years or older. I tend to refer here more to Clementine, which is part of Montanito. Montanito is 18 plus. And Clementine is under. They're part of Oliver Pyatt. I also to Veritas Collaborative, but we're family-based. So a lot of times I'm looking for family-based treatments because when they come home, they most likely will come back to us because I do a lot of transfers from our program to these facilities. I used to transfer the young ones because we also had ARFID. And so I used to transfer them to Children's Hospital of Colorado, but they seem to be taking mostly in-state. For the really severe anorexics, there's Acute, which is in Denver as well, and they will actually fly them there. I mean, like med fly, whatever that's called.
I have a question.
Thank you.
As far as the eating disorder hospitals or the ones that you were mentioning, is it completely voluntary, or are some people actually committed there? I mean, it can be a real danger, but don't they have to be voluntary?
Anthony, I don't want to take over your seminar.
No, I actually have a comment, but my comment really comes from a very specialized position. So, Kara, I'd ask you first, and then I'll
Okay.
kind of streamline it with regard to my experience.
So yes, it does have to be voluntary. It is very difficult to get somebody into a facility that's not voluntary. Um, Parents have taken over guardianship. That is a very difficult process to do. I had a young lady that I was in a totally different job. I actually was on the insurance side, and I started with her when she was 12. And when I went over to the hospital side, and there she was. And I kind of watched her until she turned 21. And all she wanted to do was die. She didn't want to eat anymore. And the parents were kind of letting it happen. And then eventually the dad stepped in and said, all right, we need to do guardianship. So they were able to get her in, but very few hospitals will take that. Princeton will, but you have to do a lot of convincing. I think RWJ will. I mean, you would know that, but I think you have to do some convincing on that one too. But yeah, I mean, that's the best I can say. There really isn't any place you can commit.
Yeah, I echo that sentiment. As many of you know, I'm a consulting psychiatrist. I'm hospital-based at RWJ University Hospital in New Brunswick, and we do see our share of cases. There is no civil commitment process for people with this condition. If we believe they are in imminent danger to themselves or others, and they were to get committed, let's say because there was a co-occurring suicide attempt, that commitment is not going to address the eating disorder. There's zero chance that it's going to. So there's no commitment for the eating disorder itself, even if metabolically it's putting the patient in a position where there's a strong likelihood of morbidity and perhaps even mortality. In those cases, as Kara mentioned, we have partnered with social work and the family, of course, to pursue guardianship, which again is a very complicated process. But the idea that something needs to be done to paternalistically protect the individual from themselves is one of a guardianship process and not a civil commitment one, not in New Jersey. Right?
No.
Yep.
The other thing that you mentioned is comorbidity. So it is like very, very difficult to find a facility to treat for comorbidity, even if they say they do. Again, I work with child and adolescents. I mean, we do go up to 21, but they have to be in school for that, to college or not, still dependent on the parents. But it's just difficult. I mean, it's Rogers does comorbidity. Timberline Knowles does comorbidity. It's just very hard. I mean, and then you have the situation that the family doesn't want them going that far. I mean, there's a lot of different, things here. And with COVID, forget about it.
Yeah.
I mean, that was just a whole nother ball game. So, and everybody does virtual, but you really can't treat an eating disorder virtually. They're all saying they can, but they really can't. We tried it, it didn't work, and you can't do it. So.
Completely
All right.
agree, and thank you for that clinical insight. It really is invaluable. But there was something you said I actually want to discuss very briefly, and that is about how a lot of primary care physicians will simply say, you need to take on more calories. That is a common practice, and it's one that we actually see in the hospital. And quite frankly, it's one that I've seen my own colleagues employ, in that a psychiatry team will be consulted, usually my team, and we actually do diagnose, we either diagnose anorexia or it's a pre-existing condition that now warrants independent clinical attention. And because of the comorbidity, severe insomnia, moderate to severe depression, anxiety, where I asked for medication choice. Well, very commonly for the depression, the choice of antidepressant is mirtazapine, which is Remeron. And the medical students are taught that this is the proper choice of medication because one of the common side effects of mirtazapine is significant weight gain. So you're actually addressing two conditions at once. Until you realize that eating disorders have nothing to do with eating. And matter of fact, putting an individual who is at the pre-contemplation stage pertaining to their eating disorder on a medication that as a side effect will result in their gaining weight is an absolute, almost contraindication. I mean, it's really counterproductive. So, because there's zero chance they're going to continue the medication when they're discharged from the tertiary care hospital, zero chance. So we see this all the time, not necessarily perhaps in a psychiatrist verbalizing, oh, you just need to add on more calories, but their choice of medications non-verbally communicates that same exact message. Similarly, severe insomnia in the hospital, which is very common because of multiple reasons. What buzzers are going off, whose roommate screams during the night, just being in a new setting. The recommendation for olanzapine or quetiapine, which are major tranquilizers. These are antipsychotics, which are very sedating. And yes, they do work. But over time, especially if you're going to continue this as an outpatient, will result in significant weight gain. And the reason for that choice of medication is similar, that the psychiatry recommendation is to start this now because it will definitely address the delayed sleep onset. It will definitely address the insomnia in the hospital, but if continued outside the hospital, it will also result in weight gain. So we're actually addressing two problems with a single medication until you recognize that the eating disorders have nothing to do with eating. If you're giving somebody with a body image disorder, which is what anorexia as well as bulimia are, any medication, whether it's named mirtazapine, olanzapine, or quetiapine, if you give somebody with a body image disorder that medication with a side effect of weight gain, that medication will be stopped almost 100% of the time. There's no way an individual who has acute active eating disorder will actually continue to take any medication that has a side effect of weight gain. So
What are your thoughts about Zyprexa though?
Zyprexa is olanzapine.
Yeah, okay.
Yeah. Now, if hypothetically somebody with anorexia said, listen, I'm at the action stage. They're never going to say that, but I'm at the action stage where, yes, I want help and I want to gain weight and I can't sleep at night. What medication would you recommend? Sure, olanzapine sounds perfect. Its mechanism of action fits perfectly. That is, its antihistamine side effect is going to definitely put you to sleep. And its antihistamine side effect is definitely going to stimulate your appetite. So if a patient tells me that, wonderful. Zero patients with anorexia have ever told me, I'm at a point where I want to gain weight back now. They just don't, right? It's a body image disturbance. And until they get the help they need, these weight gain medications called olanzapine, quetiapine, and even Remeron, which is mirtazapine and antidepressant, really need to be avoided. They're counterproductive. So again, I see this practice all the time in the hospital, and I will often go in and take them off those medications because of, I think, the potential harm they could cause at somebody, for somebody with these conditions who are at that pre-contemplation stage of not getting ready to address the acuity of their illness.
So then, Dr. T, are you talking about CB type? What are you talking about then instead of the meds for that intervention?
Well, again, if somebody's depressed, for example, it's going to sound like a cop out, but my first approach is to do something biopsychosocial. Okay. And again, the primary teams that consult me could care less about what I think should be going on psychosocially. They're consulting me as a physician. They want to know, hey, doc, what medication? Because when we discharge this patient with social works assistance, we're going to plug them into the psychosocial resources, et cetera. So the only reason why they're calling me is that they want to know which medication. I will actually look at medications that do not have weight gain as a side effect, because those are the medications that individuals with this condition will be most compliant with or most likely to remain compliant with. So it's a direct opposite approach. So that's the discussion I will have with each individual patient suffering from anorexia. Listen, today we're really focused on your depression and anxiety. I think your most likely diagnosis is blank, for which these are the approved medications. And this particular one really has little to no weight gain attached to it as a side effect, something like bupropion, for example, which is Wellbutrin, right? Little to no weight gain with bupropion, especially when you compare them to the other antidepressants like Paxil, paroxetine. So that's the logic that I employ. And that usually resonates with an eating disorder patient. And hopefully, even after their discharge, they remain compliant with the medication. And hopefully the medication was the right choice with regard to efficacy and improving their depressive symptoms as well. All right, let's actually it's at 10 o'clock now. So let's take a 10-minute break. Everybody can stretch. We'll come back and we'll begin a discussion about or on bulimia at that time. So I'll see everybody back at 10:10. Okay, welcome back. Before I actually share my screen and continue with our slides today, I did want to make a comment about Black Swan. Nina Sayer is a ballerina who struggles with her weight to a point where there are definite scenes that depict her restricting. There's one very uncomfortable scene in which, after she is awarded the top role, the prima donna, her mother bakes her a cake, and she won't taste it. So there's a fight that ensues that really gives us a very brief window into the interpersonal conflict between Nina and her mother, therefore establishing even the etiology of her eating disorder. Again, we're going to get into this, that is the etiology, in just a little bit. That said, there are additional scenes. One breakfast scene where she's presented a half of a grapefruit, and it's the presentation and the ritualistic way she eats that grapefruit, which is her only food for the morning. And again, not that eating a grapefruit is bad in the morning, but in the context of everything else, again, demonstrates restricting type of anorexia. And what I should say, I think plainly, is that when you take that presentation of the grapefruit, the scene with the cake, and then what Janice had mentioned with regard to how underweight she is in that other scene, taken together, Aronofsky's Black Swan really shapes up to be a fictional case history of someone with anorexia restricting type. However, there is yet another scene where she is in a bathroom stall. I think it's immediately after an interpersonal interaction with another dancer, where you see her facing the stall and flushing the toilet. So you only get to see her feet, but they're clearly facing the stall and she's clearly flushing the toilet. That is a that is a purging episode. And once you understand that that stall scene is purging, our diagnosis changes from restricting subtype to binge eating and purging subtype, because if an individual demonstrates both behaviors, the binge eating purging subtype takes precedence. So not only is Aronofsky's Black Swan a wonderful movie to teach aspects of anorexia, but because the particular character of Nina presents with both subtypes, Black Swan also serves as a nice case history to remind us that binge eating and purging subtype is more common. And if the individual presents with both behavioral subtypes, it is the binge eating and purging subtype that actually takes precedent, that will actually be Nina's diagnosis. So again, a wonderful movie. I know it's not the one we chose for today. It is Halloween. I wanted to focus on Hocus Pocus, say that one quickly. But I certainly wanted to allude to Black Swan for review of anorexia in particular, and certainly those two subtypes as well. So without further ado.
Can I say something?
Of course.
So, yeah, there are some professions where there's a lot of pressure to be thin. I know someone who was a young ballerina, and once she hit puberty and she got curvy, the pressure to be thin caused her to quit.
Oh, no doubt. No doubt whatsoever. Again, I don't think there's any coincidence that Aronofsky cast this as a ballerina with regard to eating disorder. And ballerinas are only but one example. Gymnastics, of course, is another very easy example. You know, eating disorders in general are socio-cultural phenomena. They tend to be culturally bound syndromes, and it's probably worth discussing this somewhat. Last evening, we had a special event with a medical school in Brazil where we had a combined joint discussion that was related to yesterday's 31 Nights of Halloween movie, which was The Cabin in the Woods. And one of the things that this particular Joss Whedon film depicts is something called culturally bound syndrome versus culturally sanctioned beliefs and behaviors. So it's probably worthwhile getting into this for 5 or 10 minutes. So culturally sanctioned beliefs, and certainly those types of beliefs that were depicted in yesterday's 31 Nights of Halloween film, that is The Cabin in the Woods, are beliefs that appear to be geographically isolated. So when an individual from a particular country or even a particular area of our own country, let's say land at Newark Liberty Airport and demonstrate their behaviors, which to observers seem quote unquote abnormal, that is, they are literally outside of what we would consider as Jerseyans normative. That particular person might actually come under the scrutiny of a psychiatrist. And if that were the case, the psychiatrist would hopefully diagnose nothing at all upon discovering that in the individual's culture or subculture, that is the area in the United States where they practice these beliefs, it is normative. So behavior doesn't change from normal to abnormal just because you cross a state line or the borders of our country, right? So the clinician must appreciate the context within which this behavior is practiced. And if it is practiced as a culturally sanctioned norm in that individual's country or area of country, there's nothing further to do. That is referred to as a culturally bound syndrome. Excuse me, take it back, a culturally sanctioned practice, right? So it's perfectly normal. On the other hand, there is another group of behaviors that are also geographically isolated. The difference, though, is for these particular behaviors, within the context of one's culture or subculture, the behaviors are deemed abnormal. And that, of course, would be the differentiating characteristic. Those behaviors are labeled culturally bound syndromes. So there is a difference. Given that very brief background, eating disorders are thought to be culturally bound syndromes. That is, they're nearly non-existent in developing countries. And the United States appears to corner the market. And now I showed you a slide previously that, while it didn't give any real numbers, stated that these conditions, the eating disorders, are more prevalent in industrialized nations, and that's true. The flip side of that, and the way to restate that, is that they are nearly non-existent in developing nations. And if that's the case, there's something to this, meaning the eating disorders being culturally bound. They appear to be bound to our culture and related, that is, as developed industrialized nations. Now, the answer then is why? Right? Psychiatry, whether it's population psychiatry, whether it's individual psychiatry, always asks, why would that be? And unfortunately, the answer is not straightforward. However, there does appear to be significant sociocultural factors that play a role in the onset and development of eating disorders such as anorexia. And that helps explain why it's as prevalent as it is in the US, but is nearly, has a prevalence rate of non-existence in developing nations. So when we say that this condition exists at a higher prevalence in professions like ballerina, dancing, gymnastics, that is absolutely true. But now you could actually see within the context that that exists, that there's sociocultural phenomena that promote these aberrant eating behaviors, this need to stay thin, to get promoted through the troop, right? One of the I think seminal scenes in Aronofsky's Black Swan is when, upon another argument with her mother, Nina turns to her mother, who herself was a ballerina, and tells her, "You never made it anywhere." That is, that's how this young girl responded to her mother telling her she has to eat. Okay? You never made it anywhere. You were in the troupe, right? You were a background dancer, right? I'm the prima donna. I'm going to be the star. And you should not be telling me how I should go about my business because you were a failure, right? That discussion is seminal to the understanding of not only Black Swan, but of eating disorder. That need to remain thin. If she doesn't, her producer, her mentor, and by the way, he's obviously got a lot of other issues pertaining to what he does to Nina, but he would fire her. And we know this because Winona Ryder's character got quote unquote too old and too heavy. She's out. Nina took her place. And of course, there's a triangle that builds not only between Nina and her producer, but also added Winona Ryder's character, who was phased out of the lead role because she no longer fit that perfect mold, right? She got too heavy. She got too big, right? So this movie is a wonderful movie to watch to really reinforce aspects of eating disorder, and not the least of which are the sociocultural factors that play a role in its onset and development. And that need to remain thin, and that need is certainly accentuated with regard to different roles, ballerina, gymnastic, etc., that require thinness. No doubt about it. All right, I will share my screen. Enough about Black Swan. And we will discuss the condition of bulimia. 1.5% prevalence among young females. Again, there's a 10-to-1 female to male ratio. This condition, number one, is more prevalent, meaning that it is likely significantly underdiagnosed in males. Commonly begins during adolescence, young adulthood. Onset again, often associated with a stressful life event or an episode of dieting. Crude mortality, about 2% per decade. Suicide rate, less than 12 per 1,000. And this is just a compare and contrast with regard to demographic data, comparing anorexia to bulimia. If FUBAR, and I saw a comment with regard to somebody having watched this on YouTube. I assure you that even though the scene you may have watched missed the FUBAR comment, there is a scene, and maybe during our next break, I'll look for it and I'll post the link in the chat room. But if FUBAR is the DSM definition, that is an acronym for the DSM criteria of anorexia, crowbar defines bulimia. So I tried my best to get the words to rhyme. Number one, I think it is critical to understand that bulimia is not only diagnosed by behavior, its actual behavior, but more specific, it's compensatory behavior. And we're going to get why that's so critical. The compensatory behavior, very specifically, is recurrent episodes of binge eating. So this is actually a condition that is defined by the behavior itself. Remember, that's not the case for anorexia. Anorexia is a condition defined through fear. This is, that is a feeling. This is something quite different. This is actually defined through behavior, specifically compensatory behavior, manifest as recurrent episodes of binge eating. Well, the next question is, well, what does recurrent mean? Well, it means that it occurs on average once per week for at least 3 months. Similar to anorexia, body image disturbance. I said before that this clinical criterion is what links bulimia to anorexia. Both are body image distortions. And AR, to finish our acronym, is that anorexia is ruled out. So if an individual presents with recurrent episodes of binge eating and purging that occur on average once a week for at least 3 months, but also has a fear of gaining weight despite being underweight, you do not diagnose both eating disorders. You only diagnose anorexia. So anorexia is ruled out. That is the AR in Crowbar. One other comment with regard to Crowbar, bulimia, and that's again looking at that first clinical criterion that this is a compensatory behavior. The question I have is, what if an individual does present with recurrent episodes of binge eating that occur on average once per week for at least 3 months, but that's it? That is, their behavior is not a form of compensation for anything, right? When you ask them, why is it that you continue to binge eat and purge? And they tell you that there's nothing going on with their body image, and that what they're observing or what the doctor observed, what their parents observed, that is these recurrent episodes are not linked to any body image distortion. They're not compensating for anything. And let's just say for purposes of our academic discussion, that report is reliable. Well, then the American Psychiatric Association understood that you cannot diagnose bulimia because this has nothing to do with compensation of a body image distortion. So while the second and third bullets ring true here, the first and fourth bullets do not. Now what? Well, as a result or an answer to that very question, the American Psychiatric Association in 2013 created another eating disorder called the disorder of binge eating, otherwise known as binge eating disorder. You can see that highlighted at the bottom right of your slide. And this disorder of binge eating is new. That is, it has only been part of the DSM-5 since 2013. And it is a variant of bulimia. That is, it is a condition of recurrent episodes of binge eating that occur on average once per week for 3 months, but there is no body image distortion. Therefore, there's no compensatory behavior that's attached to this. Right, so remove that first and fourth bullet, the slide remains, and you have this new condition called disorder of binge eating. A patient presents to you with either anorexia or bulimia, and you have to employ a treatment plan. Now, I'm not going to get into the real specific details of this because, as many of you who work in these clinics would attest, this is a very complicated problem to tackle. And it is beyond the scope of our discussion this afternoon to really get into any fine detail about what true treatment will persist with or persist of. That said, treatment in one slide looks at the biopsychosocial components of the treatment plan. So biologically, when individuals are of low body weight, below normal lean body mass, and that is usually defined by a body mass index, which is a very simple calculation of 17.5 or lower. Yes, meet with a nutritionist. Yes, employ things like calorie counts, especially in acute situations, inpatient hospitals, for example. You'd also have to be very careful when the individual does begin to employ and adopt a new diet that is refeeding, and then consider other somatic therapies like antidepressants, where the SSRIs may have a role. Now, I said before, one thing you have to be very careful of here is that the SSRIs, as a class of antidepressant medications, often confer weight gain as a side effect. So this is something that has to have full disclosure for your informed patient. Now, not all SSRIs are built equally. Medications like paroxetine do confer perhaps significant weight gain. And those like escitalopram, which is Lexapro, relatively less weight gain. So all of this should be discussed with your patient, and they should make an informed decision pertaining to which SSRI, if any, they agree to, they consent to. Now, having said that, it is inherent that not only do you discuss the particular side effects, including but not limited to weight gain, but what benefit. And that patient then should weigh the benefits versus the side effects to make an informed decision. The benefit of the SSRIs in the medical literature is primarily focused on binge eating and purging behavior. So they do have a role with regard to the biological treatment as part of your biopsychosocial treatment plan for bulimia and anorexia, binge eating, purging subtype. You have to be very careful in recommending an SSRI to someone afflicted with anorexia, restricting subtype. There really there is no real clinical evidence to suggest that the SSRIs would be helpful in that subtype. Of course, the exception to that rule is when there is a co-occurring disorder, depressive or anxiety disorder, for which the SSRI may have FDA approval, right? But that would be the exception to the rule. Otherwise, SSRIs do have benefit for binge eating and purging behavior, and therefore should be strongly considered in the conditions of anorexia, binge eating purging subtype, as well as bulimia nervosa. The psychosocial treatments just remind us that therapy should be the core to any treatment plan. And with regard to employing a treatment plan, level of care must always be considered. That is, where in fact are you going to apply the treatment? The reason why I bring this up is because clinicians have to certainly be knowledgeable of when there's a need for hospitalization. Now, what I'll do, and I'll go ahead and either post on Twitter the link, or I'll come back and I will put it in the chat room. But there are always published criteria for hospitalization for the asymptomatic patient. That is, if your patient is symptomatic as a result of their eating disorder, they have to be referred to inpatient hospitalization. The question is, what do you do for the asymptomatic patient? And there are guidelines that have been published for clinicians to refer to reference with regard to when to hospitalize that asymptomatic patient. What really is the common thread through all those criteria that I do want to mention is that when outpatient treatment is unsuccessful, it is time for inpatient treatment. Now, that sounds like a pretty straightforward, obvious part of treatment planning, but it is one really that does inform when to hospitalize an asymptomatic eating disorder patient. And like I said before, and it's worth restating, always screen for and treat medical as well as psychiatric comorbidity, right? This condition is incredibly complex, and to forget to screen for example, psychiatric comorbidity is only going to put you behind and your patient in a situation where the likelihood of success is going to be significantly reduced. With regard to, and again, the treatment planning for patients stricken with these illnesses is incredibly complex and cannot possibly be contained in a single slide. But then again, to contain it in a slide set would basically mean that we have to pretty much dedicate an entire seminar day to this. So as to condense things, I wanted to just provide a very broad stroke, and that's why I contained it in a single slide. Having said that, this does get to a medical emergency that can result when calories are reintroduced too quickly. When your patient, for whatever reason, is not taking in the proper amount of calories, maybe it's due to end-stage cancer, maybe it's due to a wasting syndrome that is the result of end-stage AIDS, maybe it's due to anorexia. In either case, if you are providing them calories, you are providing calories to someone who is in what is referred to as a catabolic state. To do so, you are going to introduce calories and potentially have a net result in phosphorus metabolism. I'm not going to get into the specifics of this, but as a result, can introduce what is referred to as the refeeding syndrome. So the refeeding syndrome is an adverse consequence of reintroducing calories too quickly in someone who, for whatever reason, is in a catabolic state. The refeeding syndrome is a multi-system syndrome. You could see by this slide that really complies to the acronym CAMRA-SHY, right? CAMRA-SHY. So congestive heart failure, the heart pump function could fail as a result of providing calories to somebody in that catabolic state too quickly. The heart could have abnormal rhythms, so arrhythmias. They could have an acid-base disturbance where your blood becomes too acidic, called metabolic acidosis. There could be inflammation of the outer covering of the heart, that is myositis, and that would include muscles too. They could become confused, a syndrome referred to as encephalopathy. There could be respiratory failure. Ataxia is difficulty walking or ambulating. They could have seizures, and then the HY in CAMRA-SHY is hypertension. They could have an abrupt rise in blood pressure. And so CAMRA-SHY is the acronym to remember the refeeding syndrome. Again, that syndrome, which is a set of symptoms and signs that are adverse consequences of reintroducing calories too quickly in someone who is in a catabolic state, such as that due to anorexia. And this is a disorder. This is a result of phosphate metabolism. All right, well, when we look at conditions, especially anorexia nervosa, what do we tackle in psychotherapy? Now, I will say that over 90% of the therapies provided to individuals with anorexia nervosa is CBT or a form of CBT. So this condition is so complex, that is anorexia is so complex that CBT sometimes doesn't even work, and CBT has been adjusted. It has been enhanced to focus primarily on aberrant eating behaviors. So CBT or some variant of CBT is really the core to not only a biopsychosocial treatment plan, but the core to psychotherapy in general. That said, I do want to get into psychodynamic and psychoanalytic theory as well. And the reason why I mention this is because it is a wonderful segue to the film we're going to watch, because even though, number one, not everyone may agree with psychodynamic or psychoanalytic theory, and even though in a practical sense, that is in practice, these are relatively rarely applied when you compare the prevalence of CBT. There are aspects of each of these theories that I think are really portrayed very interestingly in film. So to understand these theories and then to watch a film, you can then get into a discussion about how the film may be a metaphor or symbolic of an eating disorder. So that's where these theories are coming in now. So first, the psychodynamic theory of what causes anorexia. Well, for psychodynamics, again, this is Freudian, basic Freudian theory. Let's provide some very brief background. Sigmund Freud believed that we all enter this world like an animal. That is, and I'll combine this with Maslowian theory, that is, the infant was focused on their biological needs. So like a baby lion cub, like a baby snake, the human baby only cared about its biological needs. And whenever it cried, whenever it grunted, whenever it screamed, it usually got whatever it wanted or whatever it needed, right? So the baby would be fed, it would be provided drink, or it may be provided the opportunity to sleep. So change the diaper and lay it down in its cradle, right? So biological needs, that base of Maslow's pyramid, corresponds very directly to what Freud believed to be the development of the id, that is, that aspect of ourselves, our subconscious, that really housed our most primal animal instincts. That was our id. And this is universal. We all shared this. Nobody came into this world talking and verbalizing exactly what they needed, or even cared to discuss perhaps a compromise in what they needed. That just does not exist until 2 years of age. Around or about 2 years of age, Sigmund Freud focused on the milestone of toilet training, because the understanding was that at this point in one's development, they were told, that is, the child is told no for the first time. No longer can you just simply base your behavior on your biological needs, on your instincts, on your id impulses. Instead, what you needed to do was tell mom or dad or primary caregiver that you had to go to the bathroom and you will be taken into this room and you would do it this ritualistic way. And hopefully you got a reward for that behavior. That's toilet training. What toilet training did was begin to develop a sense of what was required of you and deviates from simply what you wanted to do. That is, what toilet training did was begin to develop a second component of your personality that Freud called the superego. So all of a sudden, at the first sight of that porcelain in that separate room, the child began to recognize there is self and there is other. There's what I want to do, my id, and now there's things being imposed upon me, albeit through my parents. But these are societal norms. And for the first time ever, that is, with the development of that superego, we were in crisis. There's friction between what I want to do and now what I'm allowed to do. There is friction between those instincts that are governed by what Freud called the pleasure principle that govern the id, and those societal norms that themselves are governed by what Freud called the reality principle. And Freud called this friction between the id and the superego anxiety. So here we were, anxious, as early as 2 years of age. And Freud then postulated that the reason why this anxiety was kept subclinical for most of us is because of the development of the third and final component of our personality, that is our subconscious, called the ego. The ego's main goal was to alleviate the anxiety caused by the friction between the id and the superego. And the way the ego does this is through different defense mechanisms, these subconscious processes that aim to alleviate anxiety. So that is an ultra quick 3+ minute primer on psychiatry and psychology taught by Sigmund Freud. And with that, we can now engage in what is this psychodynamic theory and how really do we apply it in understanding anorexia. Brief pause. Any questions?
Hi, I have a question. I just put it in the chat. I'm not working in a clinical setting anymore, but I have heard about binging, purging, but it's basically very specific, where someone is eating food, generally a lot of food, not swallowing it, spitting it out. So they're not purging, vomiting, but they're not actually swallowing the food. Is this something that would fall under bulimia? What are your thoughts on that?
So I think that's likely to be captured under the new category of rumination disorder, right? Which is yet another new diagnosis in the DSM-5. So the individual is actually chewing, but either spitting or vomiting it out. Definitely not bulimia, because again, the behavior is not going to be deemed a compensation of a body image disturbance. So that's not bulimia. And if there isn't true purging, it's not likely the new disorder of binge eating and purging. My gut says is that it will either be rumination disorder, or yes, the DSM-5 still does contain a grab bag category of an eating disorder that is not yet specified. So unfortunately, it may still be designated under that grab bag potpourri category.
I have a question. I have not heard you use the phrase compulsive overeating, and yet there's a whole group of anonymous meetings associated with that. Where does that stand for you?
Stop sharing my screen. That's a great question. So let's go back to one of our previous slides. I will share my screen. So as you can see, with regard to the new classification of the DSM-5, compulsive overeating is really not captured in the new system. So I guess if somebody came in with compulsive overeating, I have some questions that I need to ask to better understand what the patient is experiencing that is becoming manifest as compulsive overeating. And I think what I would be getting at is whether or not we're going to end up calling this an eating disorder that is not otherwise specified, or is it something that might be out of the eating and feeding disorder chapter altogether? Because when I hear the word compulsive, obsessive compulsive disorder has to be a clinical consideration. So one question I have is with regard to compulsive overeating, is there any other evidence of obsessions, that is intrusive thoughts that are disturbing or distressing to the patient that results in clinically significant distress or impairment? So if the answer is yes, I'm thinking that this may be a variant of obsessive compulsive disorder. The other question I have is, are there any other ritualistic behaviors that appear to undo the anxiety of the intrusive thought? So, okay, it's becoming manifest as eating, but is there anything else? Counting, cleaning, any other evidence? Because again, if the answer is yes, it looks like this is a part of a larger disorder that is either OCD or in the OCD spectrum. If the answer is no for each, and it doesn't look justifiable to consider this as part of the OCD or related disorder spectrum, then I'm thinking that as an eating and feeding disorder, it is another one that is likely relegated to that eating disorder that is not otherwise specified.
Okay. Within the self-help world, they treat it as stopping eating any white flour products and sugar, seeing that there's a biochemical, I guess, aspect to this. What do you think about that?
Yeah, so I've been told this by several people that I know, and I even heard that they stop eating things that are white. So
Yes.
I've even heard it expanded as well. I still would approach it within the same context, and that is to look at the differential to include the obsessive compulsive and related disorders. And again, if I don't think it fits there, it's probably going to be an eating disorder that is not otherwise specified. Now, the American Psychiatric Association, when they come up with this classification system, and again, it was last revised back in 2013, acknowledge that these eating behaviors are incredibly complex and really have nothing to do with eating. Again, we're dealing with feelings and thoughts that result in aberrant eating behavior. So to try to classify the full range of feelings and thoughts is nearly impossible. That is, these different designations are incredibly artificial. But they're still identified, and they're usually placed in a chapter of those conditions that have that require further consideration and research. And that's probably where we are right now with regard to what you're describing.
Okay, thank you.
So let's get at the psychodynamic theory again. I really have to stress here. What we're about to discuss, what I'm about to kind of present, has less to do with clinical application, because with all due respect to Sigmund Freud and any contemporaries, the focus of therapy as part of a comprehensive biopsychosocial treatment plan is going to be CBT or some enhanced form of cognitive behavioral therapy, where psychodynamic and also psychoanalytic theory, for that matter, come into practice is an understanding of other diverse approaches and how those approaches may actually inform a film. That is, if we could apply it to a film, or if we can pull from the film aspects of either psychodynamics or psychoanalytics, maybe we view the film differently. And that's where that comes in. So I definitely wanted to discuss this before we began our film, so that you can apply these principles and kind of actively watch the movie, looking for aspects of each of these theories. Psychodynamic theory first. So again, I gave you the brief primer with regard to the development of personality as per Sigmund Freud. That said, when we look at individuals struggling with anorexia, individuals with this condition, especially given its onset at or around the time of adolescence, are likely anxious as a result of what Sigmund Freud would have called age-appropriate pursuits. So from that perspective, if an adolescent were to be stressed, and if they were to present to you with complaints of anxiety, given their age, what are some of the questions we would want to ask them to get to an understanding of why they may be anxious? Thoughts? Again, the question is, an adolescent presents with a chief complaint of anxiety, and as a clinician, what questions do you have for them as to trying to get at the root cause of their anxiety that might be age appropriate?
I think I would be asking about relationships at home or outside in school.
Yep. I think it's very fair to start that. Issues pertaining to intimacy, right? And I use that word because, again, I want to relate Freudian theory to now Ericksonian theory. Erik Erikson would tell us that the main conflict or milestone in adolescence is intimacy. I'm sorry, not intimacy, identity, which is the groundwork for intimacy. So that's applying some Ericksonian theory to this as well. So yeah, it's exactly what we would talk about. Now, the idea here, if that in fact is the core milestone of adolescence, all right, of forging some sense of identity as a groundwork for intimate relationships, of course, difficulty with regard to achieving this would result in anxiety. Now, the psychodynamic theory states that one way to alleviate the anxiety of what, again, Freud would refer to as this age-appropriate pursuit would be to simply displace that conflict with the conflict with food. So it's a form of displacement. So the individual has their anxiety play out in food choices instead of what would be more age-appropriate pursuits, right? So they are stressed, they are anxious with regard to issues pertaining to intimacy, and this actually becomes manifest in their eating habits, right? And that's basic psychodynamic theory, right? So what Freud would say is that if an individual presented with a chief complaint of anxiety and you were provided information in the patient's history that they were having, quote unquote, or demonstrating, quote unquote, abnormal eating habits, to focus on the eating habits would be misguided. As a psychodynamic physician, therapist, other, you would really get at the symbolism behind the eating habits and understand that their anxiety pertaining to issues pertaining to sexuality and intimacy were being played out by their food choices and eating habits. That's what Sigmund Freud would say. So that's the psychodynamic theory. Psychoanalytic theory, which also is Freudian, goes even one step further. And that is that eating disordered behavior is really a manifestation of one of the psychosexual stages of development, right? So we come into this world 0 to 1 in the oral stage. At 1 to 2, as I mentioned before, Freud focused on toilet training and postulated that we were in the anal stage. And then from 2 to 5, the individual actually then evolved into the phallic stage, right? And during the phallic stage, there was the issue of relationships with the same versus opposite sex parent, right? We come to know this as the Oedipal complex. And that holds true for little girls as well as little boys. Later on, Anna Freud coined the term the Electra complex, just to label it differently for girls. But the fact is, each individual, each child, whether it's a boy or a girl, has issues pertaining to their same versus opposite sex parent. They recognize the opposite sex parent as different from self, and also recognize the relationship between that parent and their significant other versus you, right? So that's that triangle that begins to become understood by the child during the phallic stage of psychosexual development as per Sigmund Freud. If the Oedipal/Electra complex does not get resolved, one of the adverse consequences may be an eating disorder. That's the general idea. Okay. Now, I'll continue to refer to this as the Oedipal complex as applied to little girls as well, because I really don't think we should be changing the name just because the child's sex changes. The Oedipal complex is the Oedipal complex applied to both little girls as well as little boys. So the idea for the little girl is, again, they identify their dad as different from them. And they also identify that mom has this relationship with dad, and therefore I should have this relationship with dad because I'm the same as mom, right? And that's pure and simple for a child, straightforward. Okay, little girls sometimes will say they want to marry their daddy. That is perfectly normal during the phallic stage of development. Now, again, if we look at this, Freud also said that because of that desire, because of that thought, that little girl will want to kill her mom. They want to dispose of mom. They want to get mom out of the picture. Right? And that's normal, right? And the reason why this phenomenon, this complex set of behaviors and thoughts was named the Oedipal complex is because that was actually played out in the Oedipus Rex, the Greek myth. Okay? It takes its name. So at this point in time, we can look at, and again, 10 to 1 female to male ratio for anorexia, similar to bulimia. When we look at a film, and if we see that there is a young woman or girl cast as a major character who then either thinks of or commits matricide, you can see how that's very Oedipal and how that could actually be the origins of an eating disorder. And certainly as a clinician, you could see how any film that casts a young woman, young girl, considering or committing matricide as a metaphor for the potential origins of an eating disorder, right? Having said that, at that point where you pick up on this, especially after perhaps attending a seminar like this, you can begin to actively watch the film differently. And you can look for other clues as to if or why this film may be in fact about anorexia. So it's just a different way of watching and being an active viewer of a motion picture. And that would be Hocus Pocus as well. Now, when the developing brain understands that you are not allowed to kill mom, that's the superego, there's going to be a problem, because you have this id impulse which says that you want to dispose of mom to satisfy that Oedipal desire, that impulse, that id impulse. But remember, thanks to toilet training, we also understand that we are not allowed to do this. The superego will not permit this. So there's going to be anxiety. That is, there's going to be friction between what you want to do and what you are allowed to do. Well, remember that this friction, that this anxiety will always be alleviated and addressed by the ego, specifically the ego defense. Now, the individual, that is this young girl at this point in my example, can really go with any ego defense. There's no way of predicting necessarily what ego defense will be employed. However, for those that wind up utilizing the ego defense mechanism called internalization, they are put at further risk for developing an eating disorder. Because internalization, as per the psychoanalytic theory, has the individual internalize the mother object and then starve her by reducing their caloric intake in a way to symbolically kill mom. And because you're symbolically killing mom, you are allowed to, in again, your mind, satisfy that impulse, yet comply with the superego mandate that thou shalt not kill. So the ego, and specifically ego defense mechanisms in general, allow for that type of justification and compromise. And in the case of internalization, that young girl can internalize the mother object, starve her by reducing their food intake, by reducing their calorie intake, as a way to symbolically kill, comply with the id impulse, yet still comply with the superego's reality principle, thou shalt not kill. And therefore, the development of the eating disorder is now readily understood as per the psychoanalytic theory. So again, any movie that casts a young girl who considers, thinks of, plans, or even commits matricide is a psychoanalytic representation of eating disorder. So now, for those of you who have not seen Hocus Pocus, I don't want to give anything away, but that is not necessarily what's going on in this movie. One of the other movies that I had considered showing today was Stephen King's Carrie, which definitely portrays that and definitely allows us to discuss Carrie as a metaphor, that is a fictional case study of anorexia. And this is our review slide again. Films depicting eating disorder, any adolescent or young adult female must be cast. She must consider or commit matricide. And then that third component that really allows us, and this is where Hocus Pocus does come in, if they are accused or found to be a witch, that's a common variable, that is being a witch with regard to possession, right? That is, witches in folklore are thought to be possessed by Satan because they are thought to have had sex with Satan. That's what it means to accuse someone of being a witch or practicing witchcraft. And that includes what happened in the Salem witch trials as well, right? That's the idea that the witch is possessed. Well, there's a medical condition, a psychiatric condition, in which this also holds true. That is, if an individual or their family believes that they are possessed, one of the things that the clinician must consider is this idea, this illness called dissociative identity disorder, or DID. So there's a common variable with regard to what makes a witch, and then what makes someone diagnosed with DID, right? And that's this idea of possession. Well, what I'll show you later as well, we'll get to in subsequent slides, is that this phenomenon of dissociation that links being a witch to conditions like DID also itself links to the eating disorders. That is, dissociation is a significant component of anorexia and bulimia, although it's not captured necessarily in the DSM criteria. So I have that as Roman numeral 3. Again, in any movie about witches, and that includes Hocus Pocus, we have to think that there is possession, because that
Yeah.
is possession is what makes a witch. Is there a
Uh,
question?
Yep, I do. I just, as you were talking about that, I was thinking about Lizzie Borden. Any connection as far as being a witch, any DID, what do you think about that?
So a couple things is that, number one, because Lizzie Borden is a real person, what I'm about to say, full disclosure, is purely speculative. I have to say as a disclaimer that I have not examined Lizzie Borden, so that anything that I render as an opinion has nothing to do with a clinical encounter, because that would actually break the law. It would break the Goldwater law, right? So having said that, if Lizzie Borden is found to dissociate or have dissociated during the time of her potentially, presumably holding that axe, certainly I would feel that a psychiatrist who examined her may actually consider a diagnosis within the dissociative disorder spectrum, and that would include the condition of DID, defined, and we're going to get to this again in a slide later, DID defined as a distinct personality state that takes over one's conscious awareness. That distinct personality, often called an alter, may have a name, maybe Anthony, or it may be experienced as possession. And that's new to the DSM-5, right? That a state of possession counts as a distinct personality state now, as per the American Psychiatric Association. All right, so people who are possessed can be diagnosed with DID now. So let me pause there and ask if I've answered your question appropriately.
Yes, you have. You have. Thanks.
Any other questions I could take? Again, just to restate, I want to make sure the last slide was clear. We're talking about possession, okay? In 2021, and in between 2013 and 2021, if someone is reported as having been possessed, one of the conditions that a clinician would consider is called dissociative identity disorder, defined as a dissociative disorder, a mental disorder in which someone has a distinct personality state take over their conscious awareness. Prior to 2013, that distinct personality state was not allowed to be a demon. But as of the publication of the DSM-5 in 2013, it now is. And similarly, shifting from psychiatry to folklore, tongue-in-cheek somewhat. If someone is thought to be possessed, especially if that someone were a woman, and if someone were in the 14 to 1600s, they may be accused of being a witch. Right? Witches, folklore tells us by definition, are those that are possessed due to having had sex with Satan. That's what makes a witch. Right? So there is this continuum that's built between being a witch and being diagnosed with DID. And that common variable is demonic possession. Right? Demonic possession creates the witch. Demonic possession does perhaps allow someone to now be diagnosed with DID. Right? So there is that common variable. There is that continuum built between being a witch or witchcraft and this this condition of dissociative identity disorder. And that's that third Roman numeral that's listed. So any movie that captures that, along with a young female being cast in a lead role, that's like Carrie, and commits matricide, kills their mother, per Freud. That's also Carrie. Oh no, by the way, in Carrie, I should also remind you that her mother accuses her of being a witch. So Carrie checks all three boxes for us. This particular movie we're going to start in about 20 minutes also checks the box of witchcraft. And with that perspective, I want this audience to now delve into this film and begin looking for clues that there may be evidence of either a dissociative disorder and or an eating disorder. Because one of the things I'm going to try to build upon post-film is that there's a continuum here as well, that many people who have eating disorders have dissociative disorders and vice versa. And that co-occurrence is so common that many clinicians believe that they're the same condition with maybe two ways in which it becomes clinically manifest. So maybe they're a variant of the same condition.
If I may, Carrie and Lizzie Borden were both abused. They were both abused physically and emotionally. So, I also think of Sybil. I mean, the same kind of thing. Because before DID, they would have thrown this under schizophrenia. So, a lot has happened over the years.
And before schizophrenia, they would have thrown this under witchcraft. Right? If
Interesting.
you look back at the Salem
Yeah.
witch trials, and if you
Yeah.
actually look at the ledger, that there was a physician that examined those two little girls, 9 and 11, that started off the Salem witch trial hysteria / craze. And if that person happened to be a psychiatrist, the Salem witch trials likely would have never happened. Of course, that assumes that the degree of psychiatry back then was equivalent to what we know today, which is completely erroneous and ridiculous. But before schizophrenia, they would have been accused of being a witch. Right?
Yeah.
That's a great point. Now, I want to actually expand on that just a little bit before we take our break. So again, I think what my plan is to do is to take questions, have this conversation up until around 11:20, 11:30, take a brief 10 or 15-minute break, and then start this movie. Okay, but they were both abused, Lizzie Borden, as well as Stephen King's Carrie. It's Carrie White. Now, let's talk about this just a little bit, because again, for those of you who have not watched Carrie, I'll try to fill you in as much as possible to make it academic, but yet not give any spoilers away either. Carrie White was definitely abused. There's the overbearing, the enmeshed, the omnipresent mother, which Stephen King casts near perfectly with regard to Mrs. White, no doubt about it. And with that, there is verbal and there is emotional abuse. There is significant emotional abuse that Carrie endures in the opening scene in the movie when she has her menses for the first time as a high school senior in the shower. So again, in that particular scene, most of the quote unquote normal world looks at that as bullying, and they'd be exactly 100% right. However, outside of that normal cohort, there's us, right? There's this group who actually thinks about the additional layer. Not only is it bullying, but wait a minute. How did she have her first period as a high school senior? Isn't that called primary amenorrhea? And it is. So right there, we have one of those one of those characteristics, I should say, that helps define anorexia. And boy, might this movie be about anorexia? Well, you know what? She's accused of being a witch by that verbally abusive mother. She's a young female, adolescent, and she commits matricide. So psychoanalytically, you better believe Carrie, the film, is a fictional depiction of anorexia, no doubt. And let's get at the abuse. We see mom abusing Carrie, but again, the normal world has what to say about Carrie's father. Any thoughts on that? What do we know about Carrie's dad?
was pretty quiet in all of this. We don't really know much about him.
Exactly right. What we know about Carrie's dad is told to us through comments from Carrie's mom. Clearly, the relationship was not productive. He is not literally in the picture, right? Stephen King doesn't have him written into the novel, and Brian De Palma does not have him written in the script. He is literally absent, right? Certainly, he's alluded to on several accounts by Carrie's mom in a very unfavorable way. Men only want one thing, etc. Okay, so that's what we know about Carrie's dad, and that's what I think the normal world will take from it, and they'd be exactly right. But then there's us. Then there's a group like us who are, I'm trying to create, a nerd or geek element where there's something even more to that, right? In clinical medicine, we would actually call the absence of Carrie's dad in the script as a pertinent negative. That is, it's something that we should know about, but has been left out, and that's pertinent. Now, again, Stephen King may deny that. There's nothing pertinent to that. I can't write everybody into the script. By the way, I didn't write Carrie's cousins into the script either. He'd be right. De Palma would say the same thing. Sure. Okay. I'm not buying it. Right? There's a reason why Carrie's dad is not in the script. Let's make a parallel to medicine. Carrie White is a patient that presents to you in your clinic, and you provide a comprehensive evaluation. Carrie White provides a comprehensive history. In the hour plus that you meet with Carrie in your clinic, not one time does she mention her dad. Again, is that something now we're going to agree with Stephen King that is just a coincidence? There's no way a clinician would actually take that is the absence of information, as anything but relevant, right? So when you case formulate, one of the things that will come up in perhaps a treatment team meeting is, Carrie has not mentioned her dad once. De Palma hasn't mentioned her dad once. Why? Well, when we understand that what Carrie is enduring, what Lizzie Borden herself endured was abuse, even though we see and observe the abuse at the hands of her classmates in that shower, in that locker room, even though we observe the abuse, verbal abuse, even physical abuse at the hands of her mother, that pertinent negative, I want to know, what abuse did Carrie endure at the hands of her father? That's where the clinician's mind has to go, right? So with all due respect to the normal film or movie audience that has seen Carrie and would relatively dismiss the absence of Carrie's father in this movie, we can't. As clinicians, there's no way we can. Right? There's no way we can, right? And because of the history of abuse that we do know, it begs the question, what abuse did Carrie White endure at the hands of her father? Because Carrie, unfortunately, in watching this movie, does not self-report it. She does not offer it unsolicited. So a clinician must ask, right? And I think we know what the answer will be. And now I think I know why Mrs. White kicked his sorry butt out of the house. All right, it's about 20 after the hour. Any other final thoughts or questions before we take our break? We're good. All right, so let's take a break. Let's come back at, let's say, 11:35, and we'll start this movie then. Thank you.
Emily? Emily? Emily! Elijah! Elijah! Ask to see my sister Emily. Hey, but look, they conjure. Oh God, the woods! Emily! She's done for. Not yet. You wake my father. Summon the elders. Go! Emily!
Come, child.
Spit it out. And just feeding candy to ice, getting him nauseous, kind of binge eating and then puking. But the puking was more of when he was turning him around. So, but otherwise, I really didn't see that much. So I feel like I missed so much. You know what I mean? Clinically.
I actually, I don't think that at all. Remember, and I probably should give everyone a little bit of a, again, a more gestalt perspective on this, but Hocus Pocus was not made to be a depiction of eating disorder. It's not a documentary, it's not a docudrama. And the choice of Hocus Pocus, irrespective of it being October and it being fun, and therefore my thinking it would be appropriate for this group, the choice is largely to demonstrate how films that are made for no purpose within the field of medicine or psychiatry can still be used to generate discussion, to actual teach stated objectives in a seminar nonetheless. So I don't think you missed anything at all. I think you picked up on what is routine to pick up on, and that is that Hocus Pocus simply was not produced to teach eating disorders. And I would feel very comfortable in stating that if we talk to the writer producer, if we talk to Disney and asked, they would actually confirm that. What I found is that since all films provide some level of concern and risk of promoting the stigma of mental illness, that it's actually best to steer away from films that make a conscious effort to be about a mental disorder, because they're being stigmatizing, there's no excuse. If on the other hand, we see the stigma of mental illness perhaps promoted in Hocus Pocus, you know, they didn't intend for this film to be about a mental disorder. So if there's a stigmatizing element, you could see or justify that, at least relatively speaking, it may not be as harmful. So that's why movie choices, and for those of you who have been in past seminars, we very, very rarely pick films that are true depictions of a mental illness. So I think what you did observe does show that you've been attending too many of my seminars, because again, a normal audience member would not have picked up on the witch eating and then spitting out a Clark bar as being relevant. What's happening at Satan's house and the allusion to the food as quote unquote torture, which of course somebody with eating disorder might actually entertain. That is not a normal way of processing this film. Congratulations. So, and I think that your observations are quite relevant. And as are a couple of others that are throughout this script, albeit unintended by the writer or director. Any other observations? Now that I scared everybody off in terms of now unmuting, any other observations with regard to the film?
I have one. I have two, actually. One that's kind of funny, I guess, that just eating children could be pica. I don't think children are normal food for most of us. And also, you talked earlier this morning about DID and possession, so we could talk about being possessed.
Yeah, and that second point, that second observation went a long way toward why I chose this movie, why I wanted to choose a film about a witch, because in the afternoon session, I will provide you medical evidence, that is evidence-based data, of the association between dissociation and eating disorder, and therefore possession and eating disorder. So therein lies the link, and those slides are forthcoming. I do want to make a comment about the eating of children and cannibalism in particular. So prior to 2013, one of the things that it was quite easy to convince medical students and other learners of is that the eating disorders had nothing to do with eating, because there were really only two conditions published, both of which had body image distortion or disturbance as one of their diagnostic criteria. Of course, I'm talking about both anorexia and bulimia. So I often would make the comment that this particular chapter should be renamed the body image disorders. Well, in 2013, with the publication of the DSM-5, there was the inclusion of a few other disorders that I captured on the previous slide, that is in your slide set, that is in your handout. And one of them is pica, etc. What all of these new disorders have in common is that they have nothing to do with body image. So my prior comments from 2013 and earlier, I can no longer state and apply it to all of the disorders now captured in the chapter that is now known as the eating and feeding disorders. That is, there are some disorders that have everything to do with just eating, and that is pica, right? There's nothing to do with body image when it comes to pica, as we previously discussed. Pica itself is problematic eating. The clinical focus is, in fact, on eating. So I would hope that the American Psychiatric Association, in its next revision, provides two parts to this new chapter. One part are the body image disorders, and the other part are the non-body image disorders, which would include pica and those other illnesses that are listed on your slide. Having kind of provided that as a backdrop, the American Psychiatric Association's inclusion of non-body image related disorders in this new disorder chapter, that is the eating and feeding disorders, I'm baffled as to why cannibalism was not included. I think a lot of it has to do with the APA's, how do I put this? Perhaps being a little bit culturally insensitive, because cannibalism is real. And I can't believe it's continued to be ignored. If you ever want a harrowing experience, Grim Love is a movie that I would definitely recommend. It's a movie that is based on actual events, specifically with regard to cannibalistic behavior. I'm blanking on the fictional character's name, but the character is based on a serial murderer named, I believe his first name is Edwin Muse. And one of the things that I think is certainly something that should come to the attention of psychiatry, especially those that are part of the task force of the DSM, is the comments and the interviews that Muse provided once he was captured. And they all focused on how prevalent cannibalism is and how our discipline has just shut its eyes to it. And with that harrowing report and information, it does become baffling how cannibalism, and perhaps as depicted in this film, the quote unquote eating of children, would not be considered part of a mental illness as per the APA. I mean, that just doesn't make any sense at all. So I wanted to make that comment about what your observation was about the eating of children. That, of course, is cannibalism, but believe it or not, it is not diagnosable as per the American Psychiatric Association as of 2021. Now, having said that, it is very likely that if somebody like Muse was apprehended and found to have cannibalized, that very abnormal eating behavior might likely be in the context of a larger disorder, let's say antisocial personality disorder. So there may be a way to still capture the maladaptive behavior of cannibalism, but not as a diagnosis of itself. So again, good pickup, and certainly something that I think pertains to psychiatry, and in this case, the absence of a diagnostic criteria. Any other observations?
I'm just curious, when you're talking about cannibalism, I'm thinking of the cases we've all heard about with like the Jeffrey Dahmers, who, you know, had and that as being part of a, as you said, a broader diagnosis. But I'm also curious, you know, my reference for pica very often was that there was some physical deficiency. So, you know, sort of like in the animal world, a horse will chew on the wood on the barn if they want certain things, and children would eat the lead paint or be attracted to certain things as well, just really because it was kind of a physiologic urge. Is that still relevant?
Yeah, that could definitely be true. It's certainly not necessary for the diagnosis, but once you diagnose, for instance, pica, the clinician always investigates why, because the reasons why somebody may have or demonstrate behavior that is consistent with a mental disorder, let's call it pica, is varied, right? It's always biopsychosocial. And one of the biological factors that may be contributing to pica may be some type of vitamin or nutritional deficiency. Doesn't have to be, and certainly even if it is, it may just be part of a broader picture, which would also include psychosocial factors as well. But we wouldn't dismiss the potential biological factors contributing to that disorder known as pica, and certainly nutritional deficiencies would be very high in our differential. Mhm. All right, so if there are no further questions, what I'll do is I'll share my screen. By the way, in the chat room, I did put up both those links. I not only was able to find a video, it took me back to 1989, but I did find that video. The link is up there, and I even put the timestamp in the chat room as to where you can actually find the allusion to the acronym FUBAR. And then the other link is to a website that provides hospitalization criteria for the asymptomatic eating disorder patient. Very common conundrum. Again, for symptomatic eating disorder individuals, it's easy. They've got to go into the hospital. The complexity is when someone is asymptomatic and you should still hospitalize them, right? So that link is also now up in the chat room. Here's where we left off. A couple of quick observations. I don't know if this made your handout, but in Hocus Pocus, we do know that in addition to the comments that were just provided after watching this movie, that Sarah is preoccupied with being pretty. And that's pretty pervasive throughout the entire film, and starts as soon as she reawakens. On the other hand, her older sister, Winnie, also demonstrates a disturbed body image as depicted by this part of the script, right? So this is a copy and paste of the actual script. And you could see that she's struggling. She's crying, she's tearful, she's dysphoric. And she talks about the other characters having been jealous. What's interesting here is that this is likely projection. It is Winnie that's actually jealous of the other character's body, her physique, etc. And she gets into a dialogue that she doesn't even know me, consoling her sisters. I know. I always wanted a child, and now I think I'll have one on toast. So this particular dialogue directly connects these feelings of distorted body image, the jealousy and the envy, those id wishes and impulses, directly to food, as it ends with a joke on toast, but I couldn't help but connect the thoughts with the actual behavior, in this case, behavior specific to the ingestion of food, in this case, on toast, right? So body image disturbance, looking towards the center part of your slide, connects directly to the abnormal eating behavior. One of the things that does come up with regard to hospitalization criteria is that beyond the eating disorder itself, if an individual has a co-occurring mental disorder that in and of itself warrants treatment at a level that is no less restrictive than an inpatient psychiatric unit, you must hospitalize, right? So again, if someone has an eating disorder and it is quote unquote under control, if they have a co-occurring mental disorder that itself warrants independent clinical attention at a level no less restrictive than an inpatient psychiatric unit, you must hospitalize. So identifying and treating comorbidity is central to treatment planning for eating disorders. And the first condition I want to review with you is borderline personality disorder. Here are very brief objectives with regard to what we're going to cover in the next few slides. Demographic data, 1.6% in our population, certainly higher in primary care settings, 5%. And look at the way these numbers work. They double, right? 5% in primary care settings, double that in outpatient mental health clinics, and double that among inpatients, right? So 5 to 10 to 20 as you go to more specialized care, primary care, outpatient psychiatry, inpatient psychiatry. All right, so what in the world does this slide get at other than Tobia's affection for Mel Brooks in general and Young Frankenstein? Well, if you work at 12 o'clock, and if you work, and we'll do this clockwise, I want to describe to you what the 4-part definition of a personality is. Number one, we're at 12 o'clock now, so we're at the topmost pick. And you could see a young Frederick Frankenstein, portrayed by Gene Wilder, who at this point in time is impulsive with regard to his reaction. This particular scene is incident to the discovery that his counterpart, Igor, has allowed for an abnormal brain to be put in to the corpse, the specimen that is to be reanimated. Of course, this results in a hostile monster that is portrayed by Peter Boyle. So the reaction is one of affective instability. Gene Wilder's character, and I wish I had a GIF for this, but he begins yelling in a very labile way. That is affective instability. Moving over to 3 o'clock, now we're going clockwise, and you see the pic of that very abnormal brain. In this case, Igor will choose this brain as an act of impulsivity. So in addition to affective instability, we also have impulsivity as a sign, as a domain of a personality. Working to 6 o'clock, now that third pick at the bottom of your screen, we now recall this maladaptive interaction between student and teacher, where a student asks a question. Dr. Frankenstein answers it in a certain way, but the student persists with regard to re-asking the question, putting the teacher in a very, very uncomfortable situation. This is interpersonal functioning, right? So again, in review, working around the clock, we have, as part of the definition of what is a personality, there are 4 answers. Number 1, personality is affectivity, it is impulsivity, and it is interpersonal functioning. Finally, at 9 o'clock, we see that 4th and final domain of personality. This scene is when the doctor and Igor are digging up the corpse. And as things are as bad as they are, Igor turns to Freddie Frankenstein and says, well, at least it's not raining. And it begins to pour, right? The individual who has the mindset of, well, at least it's not raining, is providing some evidence of what is referred to as cognition. That is the way we process information in our world. And when we think of cognition, we start thinking about it in one of 2 ways. Cognition is positive, glass half full, or cognition could be negative, glass half empty. I think I got that backwards. Well, be it as it may, I think you understand where I'm coming from. In this case, well, at least it's not raining. That's a positive cognitive process. The individual who looks at the glass as always proverbially half empty certainly would have that negative cognitive process. So that's what that scene captures here. Again, they're grave digging. As bad as things are, here they are in the middle of the night digging up a fresh grave, and Igor turns and says, well, at least it's not raining. And certainly, well, of course, in true Mel Brooks fashion, the next thing you hear is a thunderclap, right? Cognition. So just to review, if you asked a psychiatrist, if you asked a psychologist, what is personality? Depending on their reference, you can get any one of dozens of answers. You can go by way of Freud. We've actually previously discussed that. You could go by way of any theorist. But if you go by way of the DSM, you have the most simplistic answer in defining what is a personality, because the DSM and the American Psychiatric Association provide the answer in 4 parts. Again, in review, this slide, personality is number 1, affectivity, impulsivity, interpersonal function, and cognition. Well, when we then apply this to the borderline personality disorder, the acronym for the DSM criteria that I built for you is SALEM-MAS, which of course directly links to our movie today. Individuals with this condition will have 5 of the following symptoms. Number 1, individuals with borderline personality may demonstrate stress-related paranoia or severe dissociative symptoms. If they demonstrate severe dissociative symptoms, you can now begin to build the link between this condition and the dissociative disorders. And even though I'm not going to get into any further demographics, the comorbidity between the dissociative disorders and borderline personality is significant. I'm not going to give you an actual number. Again, I want to get away from actually giving you prevalence rates at this point, but it is significant. A stands for anger, L, labile mood, E, emptiness. M in Salem reminds us of Mel Brooks, and you can look down just a little further on your slide, and that is a pattern of unstable and intense interpersonal relationships, and that is the behavior that, again, I described as that medical student having with his professor, Frederick Frankenstein. Now to the right of your slide, we start off again with Mel Brooks. Another reference, bottom of your slide, impulsivity in at least two areas that are potentially life damaging. One of those might be when you impulsively take a brain off a shelf. That is abnormal for transplant into a corpse so as to create Frankenstein's monster. A stands for abandonment, S, self-image, and that final S includes suicidal thoughts. Any five of the following rules in for borderline personality disorder when the above endorsed symptoms cause clinically significant distress or impairment, but then again, as per our previous slide, you already knew that. Literature search focusing on articles published between 95 and 2007 assessed the strength of the evidence of there being causality between this condition and childhood sexual abuse. And the review, which was in Current Psychiatry, citation at the bottom of your screen, was that the evidence supports this causal relationship. Now, again, the causes for borderline personality are often multifactorial, biopsychosocial. However, one psychosocial cause is related to early childhood sexual trauma. So is there a relationship between eating disorders, our topic for today, and borderline personality disorder, abbreviated here, BPD? And the answer simply is yes. That is, if you look at an eating disorder population or cohort, borderline is present in about a quarter of individuals with anorexia and a little bit more, 28%, in those with bulimia. And when you compare the 25% and 28% clip, it is significantly higher than the 6% that would be due to chance alone. That is the 6% prevalence in the general population. So again, it's almost 4 times more prevalent in those with anorexia than the general population, and 4 to 5 times more in people afflicted with bulimia. And this table, again, just gets at that prevalence rate as well. So if we begin to look at this film, this fictional case study called Hocus Pocus, the question then resonates, not only is Hocus Pocus about eating disorder, but perhaps it's even about the eating borderline cluster. That is, evidence of borderline personality traits in any of the characters, which strengthen our suspicion that this movie is in fact about eating disorder as well, given the relationship that has been established in the medical literature between the eating disorders and borderline personality disorder. So I include this slide more as a heuristic, more as a rhetorical question. I don't need for us to actually delve into this, but again, it's food for thought, it's rhetorical. Next question is going to focus on a group of disorders referred to as the dissociative disorders. Again, here are our stated objectives. And I think I want to spend a little bit of time on this slide, especially as it relates to this film and perhaps even other films. So let's start out at the bottom of the slide. Let's go with the bottom and work up. There is a condition called depersonalization derealization disorder. Now, the actual definition as it is in the DSM is very straightforward and very simple, and it's actually, I think, important in saying it out loud to really establish how very simple the diagnosis of depersonalization derealization disorder is. That is, this condition results from clinically significant episodes of depersonalization and or derealization. Pretty simple. Those that rule in for the disorder account for about 2% of the general population. So 2%. Now, having said that, I think it's intuitive that the very next question anybody would have is, well, what exactly is depersonalization? And then, of course, what exactly is derealization? I want to briefly pause. Anyone in the audience have any guess as to what depersonalization is?
I have a client who's diagnosed with it. I brought it up a few times ago. And she actually saw people as not real, that they were either robots or and this included family. And so she was diagnosed with that.
So I would, I think the diagnosis is in fact accurate. I think what you're describing is derealization, and that is there is aspects of one's environment that are deemed or subjectively experienced as being unreal in some way. And if it's people around her feeling as if they are robots, I think that is a fairly straightforward example of derealization, which per the definition would rule her in for depersonalization derealization disorder. Does that make sense to everybody? So derealization is the subjective experience of one's environment being unreal in some way. Then depersonalization is the subjective experience that oneself is unreal in some way. Now, for your client, was it other people or was it themselves?
No, it was definitely other people. And at the time, I think she was also drinking a lot. I don't know, but I spoke to her last week. She was very anxious. And what ended up coming out that never did was she was abused by a teacher and she was triggered by it and then started seeing the robots again.
Yep.
So,
All right. So again, her experience of others as unreal robots is an example of derealization, which would rule her in for this disorder. Again, depersonalization is a little different. It's a similar concept, but as it relates to oneself. That is, I don't feel right, or part of me, my left arm feels as though it's under the control of somebody or something else. That's depersonalization, right? In either case, the single best diagnosis is depersonalization derealization disorder, again, accounting for 2% of the general population. Now, on a subsequent slide, I do make the point that when individuals have these subjective experiences, the clinician must rule out that they are not due to the direct physiologic effect of a substance or another medical condition. So one of the parts of the treatment plan here would be that her alcohol use be the focus of clinical attention, because if she could still relate the subjective sense that others are robots in a period of sobriety, that would really confirm the diagnosis. And while alcohol can do this, the class of drugs that are most likely to do this are going to be the hallucinogens. And we're going to get to that in a subsequent slide. Dissociative amnesia has an intermediate prevalence of 1.75. Dissociative amnesia is just that. It is focusing on that second part of the term, amnesia, that is dissociative in nature, that is etiology, right? So these are gaps of memory that cannot be attributed or explained by normal age-related forgetfulness. That's the definition of amnesia. And when the amnesia cannot be found to result from any physical problem, it is likely attributable to a mental or emotional one, hence dissociative amnesia. Now, my question, if you don't mind answering about your client, is there any evidence of amnesia with regard to her report?
No, when she was drinking, and she's been sober for 2 years now, when she was drinking, she did black out. Is that considered amnesia?
No.
Okay.
No, because again, those gaps in memory would be readily explained by an underlying medical condition or the direct physiologic effects of a substance. Blackouts are due to the substance.
Right, right. But no, otherwise not. And I know panic. I know she wanted to run out, but no amnesia. It was just a trigger of feeling unsafe, which again just came, and I'm seeing her over a year. This just came out that she was abused.
Yep, understood. Yep. Now, let's just say, for discussion's sake, hypothetically, that she did endorse amnesia, and it was amnesia that was not attributable to normal age-related forgetfulness. Then how does that new finding implicate our diagnosis? Anybody have any thoughts? The answer is that the only diagnosis that the individual should receive is that of dissociative amnesia. That is, you don't diagnose both. If someone presents to you with dissociative amnesia, they will convey or report to you these gaps in memory, but they are also very likely to report to you feelings of depersonalization and perhaps even derealization. And if that's the case, all of this is considered to be attributable to the amnesia. And there's no reason for the clinician to add a second diagnosis of depersonalization, derealization disorder when the individual has evidence of both. Dissociative amnesia takes precedent. Any questions about any of these two conditions up to this point? Well, the final condition is dissociative identity disorder, or DID. You could see it has the lowest precedence or incidence. And DID, we've alluded to before. DID is when the individual has a distinct personality state, and that could include an episode of possession that takes over their conscious awareness. And because of that, when they are awake and alert again, they will have gaps in memory during the time that that other personality state was operating. So if an individual presents with evidence of a distinct personality state and rules in for DID, you do not diagnose dissociative amnesia along with the DID. That is, the amnesia is fully explained. DID. And by the way, so is depersonalization. So with all the above, DID will take precedent. Again, the point prevalence there is 1.5%. And you can see how it's graded. The most severe, okay, the least prevalent, the mildest, the most prevalent, and then the intermediate dissociative amnesia has intermediate prevalence at 1.75%. Any questions about this very quick overview of the three conditions that are in the dissociative disorders chapter? Again, quick review for your handout, exactly what we just reviewed. In each of these conditions, reality testing must remain intact. That is, the individual should not fail reality testing. If they do, all of the above may be due to a psychotic process. So that's something that will be part of the clinical evaluation. And as I mentioned before, none of this should be attributable to the direct physiologic effect of a substance or another medical condition either. Multiple substances can induce dissociation, but the ones that I think are at the very top of the list are the hallucinogens. Hallucinogens themselves come in 3 subcategories. There are the psychedelics. Examples of psychedelics would include LSD and psilocybin. There are the deliriants. These are medications and drugs that can lead to confusion. Deliriants include over-the-counter medications such as Benadryl. And then finally, there are the dissociatives. These are the ones that I think would be most concerning with regard to dissociative states like DID. Dissociatives include ketamine and PCP. Right, so those are the examples of dissociatives. So in the setting of DID, or really any of the dissociative disorders, the dissociatives would be at the very top of a clinician's list, including urine drug screen, and certainly a clinical history inquiring of any use or experimentation with drugs such as PCP or ketamine. By the way, any idea of a film, not Hocus Pocus, that might be dissociative induced DID? I'll stop sharing the screen for a second. So a film about DID that, especially at the end of the film, there's evidence to suggest that everything that you had been watching up to that point may have been induced by a dissociative.
Yeah, the 3 Faces of Eve.
You'll have to remind me, I haven't seen that movie in quite a while. In the 3 Faces of Eve, what evidence in the movies provided that
She had 3 different states. And one would come out and the other 2 didn't know them. And eventually at the end, she became strong enough that there was only one her. There was one Eve. I think it's like Sybil.
it is similar to Sybil, yeah. I mean, again, I do recall the film. I just don't recall.
It's an
Okay.
oldie, Eva Marie Saint.
yeah.
I just dated myself. Yeah.
That's fair. Do you think there's evidence in the film to suggest that everything was substance induced, specifically a dissociative hallucinogen?
No, I don't think so. Not that I recall. I
Any
know
more-
one state, she was a party girl, but I don't think alcohol had anything to do with.
She didn't go to any raves. I don't know if did raves exist back then.
I don't think so. Eva Marie Saint's in her 90s now, so I don't think so.
God bless. More contemporary film about DID where there is evidence to suggest, albeit at the movie's ending, that it may all be attributable to a dissociative hallucinogen.
There's 2 I was thinking of. I don't know. I was thinking either Beautiful Mind or Shutter's
That's
Island.
what I was thinking of.
Yeah. Or Shutter's Island. I mean, I'm not sure if that's yours to be.
They weren't the ones I was thinking of. However, I will say this: if anybody does enjoy or did enjoy Shutter Island, we're having a special event next week with the University of Massachusetts to discuss, quote unquote, what that film is really about. Right. So
Yeah.
your hint already is, I don't think it's about DID or a drug-induced DID. So that's the only hint I'll give you, but I'm not going to give you any more.
Okay.
If you're interested in joining us, I could probably get you the link. Just let Noel or Ricky know, and we'll get you the link to next week's event. It's either going to be on the Monday or Tuesday. I actually emailed them during the film to confirm.
There's a
Could it be
movie with
Wizard of
Richard
Oz.
Gere.
Have we talked about that Wizard of Oz? And the copies or?
Yeah, Wizard of Oz. I'm perfectly cool with the poppies and this being an opiate-induced mental disorder. I can see how you can make the Wizard of Oz about DID with regard to the three characters being alters of Dorothy. I'm cool with that. So I'll give you a point there. Yeah, yeah, I like that one.
Psycho.
There's a movie with Richard Gere. I think he plays a lawyer and he's defending. I don't really remember. I don't remember the specifics of the movie except for he's defending a kid who did something horrible. I don't know if he murdered someone. And in the end, he switches. Do you know what I'm talking about?
Yeah,
that's
it's
a great
Primal.
movie.
And I think it might be Edward Norton. Edward Norton's definitely the
It is.
character.
Yes.
Yeah.
Yes.
Yeah,
Is
and I
that-
think it might be Edward Norton's first film too. I have to check that, but it's definitely Edward Norton portraying the person on trial.
And was it just a trick, like he was just manipulating? I mean, I just don't remember. Or is that something that you think would be a good example?
All right, so I will say this: it isn't about a substance-induced DID. It isn't. What it is about, I'm not going to say because it has a twist in the ending, and I don't want to give any spoilers away for anybody who may want to watch it. So,
Okay, yeah, I
but
just didn't remember.
good one. Now, the one I'm thinking about is Split. Right? Anybody here ever see the movie Split with M. Night Shyamalan? Right.
Yes.
All right. So, I mean, again, we won't give anything away here. No spoilers. But for those who have seen Split, are you okay with saying that this movie was about DID?
I guess my only issue is I know there's a lot of controversy around the movie because it associated mental health illness with without giving anything away, with the aggressive, violent, cannibalistic behaviors. So I guess, I feel like that, bothers me as well. I think that's an issue.
And I agree with you. And I think what you just brought up is some of the evidence that supports that this was drug induced. Right. So in this movie, there was the intent by the producer, M. Night Shyamalan, to create a character with over 30 alters. But what M. Night does at the end, and I think this is completely inadvertent. I think if we asked him and put him on the spot, he'd say, "No way did I plan this." But this particular person lived. Remember where he lives, Nicole?
He lives in that building basement. I forget if it was a basement of a church or a library or something, right? I don't remember, but it was the basement of something.
Yep, it's the basement of a zoo.
Oh, that's right. Yeah.
Yeah, and that reminds us that ketamine was and continues to be used as an animal anesthetic. And of course, humans abuse it for its dissociative properties. So the fact that this film was set in a zoo provides us evidence that this particular character, his name is Kevin Crumb, has access to ketamine, and would certainly explain the aggressive nature with which his alters personify and demonstrate. So it even kind of makes some excuses for the writer-director as well. But the fact is that M. Night, again, we'd have to ask him, of course, but my suspicion is that his setting this to a zoo had nothing to do with us wanting to make a connection between this anesthetic called ketamine and how everything we see may in fact be hallucinogen induced, right? But it is a clever, I think, twist at the end that allows for the discussion of Split to be not only about DID, but about a substance-induced DID, specifically the hallucinogen, more specific subtype, the dissociative ketamine-induced DID. All right, with that, I'll take you back to our slides. So is there a relationship between eating disorders, again, our topic of the day, and dissociative disorders? Well, dissociative symptoms are in fact overrepresented in individuals diagnosed with eating disorders. So it is true. That is, if you look at the prevalence of dissociative symptoms in eating disorders, that number, that rate of prevalence is significantly higher than the general population. And it in part reflects a common origin. I'm going to skip over a couple of slides. Oops, sorry. Oh, sorry. I inadvertently skipped over the slide. Outpatient studies have suggested poor treatment outcomes in individuals with higher levels of dissociation. So if an eating disorder patient is referred for outpatient treatment, and hopefully they are, those with co-occurring dissociative symptoms tend to do worse than eating disorder patients without dissociative symptoms. And then the stratification of subjects by subtype showed highest level of dissociation in individuals with anorexia, especially anorexia of binge purging subtype, right? So we even see a risk stratification in that individuals with anorexia, binge purging subtype have worse outcomes. I'm going to skip over a couple of slides and get again to the rhetorical question then, is Hocus Pocus about an eating dissociative cluster? And the only comment I'll make with this is that I believe, again, only because of my my perspective on the folklore behind witches, is that Hocus Pocus is definitely about dissociation because it's about witches. So that's one and the same as far as I'm concerned. And that's reflected in the previous slide that I showed you just prior to our breaking to watch the movie. Even though today's topic is eating disorders, we've discussed both dissociation/dissociative disorders, as well as borderline personality disorder as related to eating, but are they related to each other? That is there a connection between dissociative disorder and borderline personality disorder? Well, a study looking at adult female inpatients with borderline showed that they may experience pathological levels of dissociation. Some of the stats, 1/2 scored high on the dissociative experience scale, or DES, and more than half reported a history of early childhood physical and/or sexual abuse. So there's a common etiology that was also demonstrated in this cohort. In a recent meta-analysis, so in looking at a bunch of studies, combining them so that you have triple, quadruple, etc., number of subjects in meta-analysis that utilize the scale, only dissociative disorders and PTSD had higher mean scores than borderline did. That is, that borderline, as well as dissociative disorders themselves and PTSD, rated the highest with regard to the DES scale. In more severe borderline presentations, dissociation is associated with more non-suicidal self-injury. We often refer to this as NSSI. An example of such would be cutting, right? So again, there is this relationship with regard to dissociation and borderline. So with regard to that prior study, it brings up yet another illness that I think we have to briefly review, and that's post-traumatic stress disorder. Because of this common etiology of trauma, to look at individuals with eating disorder to look at individuals with borderline personality and to look at individuals with dissociation and dismiss PTSD would be malpractice. So in looking at these different combinations of symptoms and how there are different rates of comorbidity between the three illnesses we just discussed, eating disorder, borderline personality, and dissociative disorders, now we have to look at PTSD as well. Again, our stated objectives. Demographic data. Before we actually get into PTSD, let's take a short break. It's 2:20. Let's take our final 10-minute break and stretch, and we'll come back promptly at 2:30 and complete the rest of our slides. All right, welcome back. We're here for the stretch run. We'll take this to about 3 o'clock. There's a little bit more to include. I certainly want to review the idea of post-traumatic stress disorder and what role PTSD may play in eating disorders in general, as well as the different continua we built between eating disorders, borderline personality disorder, and even the dissociative disorder. So it becomes a very complex a cluster of symptoms that really encompass 4 separate disorders, at least 4 separate disorders as they are presently categorized in the DSM. So with that, are there any questions to start our final session?
Dr. T, could you just give us an example of what that patient would sound like who had borderline and dissociative disorder? What would that present to you like in a session?
Okay, so let me, with that question, Janice could verify this. She had not texted me, but that is the perfect segue to get to our slide set. All right, so let's look at this particular continuum. So thank you for the lead-in.
Okay.
Again, Janice is not a plant here. So here we go. This is a slide. These are some of my more intriguing favorite depicted characters in film. Carrie White, previously alluded to in the morning session, I believe works on in eating disorder, dissociative spectrum. Now working our way clockwise, we're looking primarily now at Reagan, who I believe works on a dissociative borderline spectrum. Dissociative with the inclusion of rule out eating disorder spectrum. And then look at Alex Forrest, bottom left from Fatal Attraction. I believe Alex is on that borderline dissociative spectrum. So these 3 characters really do complete a triangle and allow for the clustering of these illnesses, which really fall under the rubric of post-traumatic stress, if not true post-traumatic stress disorder. And by the way, Nina Sayer, now populating the middle of your screen, really does encompass all of the above. Okay, Nina has PTSD, like Carrie, eating disorder / spectrum, like Reagan, DID / spectrum, and then of course, what we're going to talk about and briefly allude to now, Alex Forrest, borderline / spectrum. Getting to our question. So Alex Forrest, who is on this borderline dissociative spectrum, this particular film, the fictional case study known as Fatal Attraction, depicts a character, Alex Forrest, who meets every single DSM criteria for borderline personality disorder. There isn't one published criterion taken from Salem, Mass, previous slide, that Alex does not depict in the, I think, 1987 film. In addition to having borderline personality, Alex is prone to significant dissociative episodes. There is one scene in which she has been rejected by Dan Callahan. She buys him 2 tickets to an opera that she, of course, wants to share, and he stands her up on a date. And as she sits there waiting for him, she is sitting down. I'm trying to paint the image of the actual scene itself. She is sitting down in her apartment, and with her left hand, she is reaching up and just clicking on and off her lamp. And the scene just holds there for 5 to 10 seconds with her staring into nothing. That is dissociation. And while that is part of borderline, during this movie, there is evidence that those episodes are severe enough to warrant independent clinical attention. And when a clinician deems that that has in fact taken place, that is the type of patient that is likely to present with this duality, with this continuum illness of borderline and dissociative disorder. Right? So I think Alex Forrest's character is, albeit a fictional example of an answer I would provide to that question. What would someone, or what could someone with this borderline dissociative spectrum look like? Well, it's borderline personality, and it's dissociation that, while contained within the definition of borderline, is severe enough to warrant independent clinical attention. If you watch that one scene with the lamp in Fatal Attraction, it is that type of behavior that might lead a clinician to suggest or determine that their dissociation is severe enough to warrant that independent clinical attention. And that's the continuum then that is built. Janice, does that answer your question?
Yes, got it. Thank you.
You got it.
Great movie.
I agree, and they all are. Again, working from top clockwise, Carrie, classic. Don't even get me started on The Exorcist. And then, yes, I agree with Janice. Fatal Attraction, wonderful film. And by the way, again, all of the above, including PTSD, center slide, and that's Nina Sayer from Aronofsky's Black Swan. Again, our stated objectives for the final portion of today's seminar. Demographic data, about a 9% lifetime risk of PTSD. Highest rates found among survivors of rape, military combat, and captivity. The slides that I'm going to present were actually made for a Joining Forces seminar that is warrior-centric healthcare. We were provided an opportunity to present multiple slides in this particular mission with regard to joining forces, and that's where these slides actually come from. So the way to think of and certainly recall the different aspects of post-traumatic stress disorder are to think along the 4 or so slide sets, that is, different parts of the definition. The first part is often referred to as re-experiencing symptoms, right? That is, reliving the event. I think when most people think of this particular part of the definition, they very clearly think of those thoughts and memories that are recurrent and intrusive. What they usually don't think of are the dissociative symptoms. Again, there's that connection with not only dissociative disorders, but perhaps even dissociation seen in the context of borderline and even in the context of eating disorder. Overt psychological distress, and even there is norepinephrine, that is abbreviated NE here, norepinephrine physiologic reactivity. Of course, this may manifest very often as panic-like symptoms. So people with dissociative symptoms, psychological distress, and even panic-like symptoms here captured DON as part of the acronym DON'T. The second part of the definition is avoidance/numbing. The first is avoidance. People can avoid things that are internal as well as external. And while I think most clinicians are very astute in inquiring about avoidance of external things like people and places, that's intuitive. Are there people that you tend to avoid? Are there places that maybe remind you of your trauma that you find yourself avoiding? Very, I think, intuitive questions. What is less intuitive is to inquire about the avoidance of memories, thoughts, and feelings, those things that are internal to the individual. We may often forget to inquire about avoidance of those internal aspects. And where this is potentially problematic is when a patient tells us, when a consumer, client, patient tells us, I do not avoid other people. and I don't avoid places. And if you forget to ask about those internal aspects, you may then deem inappropriately that the individual therefore is not avoiding. So very important to remember the internal as well as the external aspects of avoidance. The other part of this are those negative alterations in cognitions, which are remembered by the following acronym. So HONOR, INR. They have a hard time experiencing positive emotions. They have great difficulty allowing themselves to experience positive emotions. They could have out-of-body experiences. They could have negative emotional states. There are the organism's cognitions that are often distorted. There's recall of important aspects that are impaired. Negative beliefs are exaggerated, and there is reduced interest, otherwise referred to as anhedonia. So HONORIN, R. And finally, the hyperarousal, feeling keyed up, hyperarousal state is the final part of the definition. And the acronym here is HEROES. So when you put all of these together, bottom left of your slide, don't avoid honoring our heroes, right? So again, this really gets at the warrior-centric joining forces program that we were part of with the Obama White House. Heroes, there's hypervigilance, early morning awakenings, reduced concentration, outbursts of anger or irritability. There's an exaggerated startle, and there's self-destructive behavior. Right? And if you look at the bottom left with regard to the full acronym, that is the full set of diagnostic criteria, I think as I've been reviewing these slides, it's easy to convince yourself that there is significant overlap with a lot of other signs and symptoms we've been reviewing throughout the day. Those attributed to eating disorder, those that may be attributable to borderline personality, and of course, those that are also attributable to dissociative disorders, all contained in post-traumatic stress disorder. And that shouldn't really surprise anyone, because as we're talking about now these four as being highly comorbid and co-occurring, one other perspective is that perhaps we're talking about a single illness with different variants, right? That's a little bit more conceptual. The American Psychiatric Association has not yet adopted that conceptualization, but a lot of clinicians have. And the discovery that all of the above, whether we call it eating disorder, whether we call it dissociative disorder, borderline personality disorder, and even PTSD, have a common variable of trauma as etiology, which again, should not surprise anyone. 80% are more likely than those without PTSD to have symptoms of at least another mental disorder. So I want to go into a little bit of the data here that does suggest significant comorbidity between PTSD and, now working your way down the slide, eating disorder, borderline personality, as well as dissociative disorder. PTSD and eating disorders. There is, or has been found, a significant association between a history of trauma and eating disorder symptoms. I think we've already established that. There is a significant association between a history of trauma as well as PTSD symptoms. The relationship between trauma and eating disorder symptoms was significantly reduced when PTSD symptoms were included in the regression analysis. And what that means is that there is significance of that PTSD construct, right? What I mean here is that, and I want to explain bullets 3 and 4. Bullets 3 and 4 get at that very idea that when you're looking at PTSD and eating disorders, you might actually be looking at a single diagnostic entity, and that there might not be true variation and separation between what we right now call PTSD versus eating disorders. That's what those last two bullets get at. There are significantly higher rates of sexual and aggravated assault among women with bulimia. And when you compare this to women without such a diagnosis, there is support for the hypothesis that victimization may contribute to the development and/or maintenance of bulimia. Next is the condition of borderline personality disorder, and more specifically, its relationship to PTSD. Here we looked at data from the collaborative longitudinal study of personality disorders, which accounted for 186 women that were divided into three groups. Those women that had just PTSD, those women that had just borderline personality disorder, abbreviated here as BPD, and those women that actually had both conditions, PTSD and borderline personality disorder. The additional diagnosis of borderline in women with PTSD significantly increased the features of suicide proneness as well as impulsivity. Both groups of women who had PTSD, that is the PTSD only group, as well as those with PTSD and borderline, reported significantly more types of childhood trauma relative to borderline women without PTSD. And then finally, the association of dissociative disorder with PTSD. And this gets at the very definition of post-traumatic stress disorder, which again was amended in 2013. Prior to 2013, there was no specifier for post-traumatic stress disorder. With the revision of the DSM-5, the American Psychiatric Association ensured that there are now specifiers of PTSD with either derealization or depersonalization. That is, it was the APA's acceptance that dissociation is part of the illness known as PTSD. So we see a merging of these separate illnesses where now PTSD may include derealization and or depersonalization as specifiers. So that again gets us to this very slide. Maybe there are no discrete boundaries between what we understand as Carrie White, eating disorder, Reagan, DID, Alex, borderline personality. And maybe it's the case of Nina, who in Black Swan encompasses all of the above, that is the true presentation. And that is, it is a 3-in-1 illness. And maybe that 3-in-1 illness should be accurately labeled PTSD. Which brings us back to our question, is Hocus Pocus representative of this? I keep on referring to Aronofsky's Black Swan, but maybe today's fictional case of Hocus Pocus is in fact demonstrative of this clustering of what is now thought of as 3 distinct illnesses, but maybe is a single illness, and perhaps its name is PTSD with different variations and then different expressions. So, and if that's the case, who in this film is, or I should say, whose eyes, whose perspective is this film Hocus Pocus actually told through? And it might be actual Sarah Sanderson, given how often she refers to her looks, her being pretty, as being central to her understanding. Now, we will say this as well. I want to just briefly, again, stop sharing. Remember, the introduction to this movie, again, I don't think necessarily bore a terrific amount of relevance with regard to the writer or producer, but it cannot go, I think, without focus from our perspective. And that is that these Sanderson sisters underwent significant trauma in early Salem. They were killed for what they practiced. And although in Hocus Pocus, we actually rely on folklore and that they seem to be quote unquote real true witches, but that's the Disney spin. Of course, the Sanderson sisters in real Salem or Salem Township were not witches, but they were killed anyway. So that establishes the trauma and further supports this clustering of illness that might be post-traumatic stress. Okay. Brief pause, we have about 10 minutes left. I do have one more thing to get to as quote unquote bonus coverage, but first I want to ask if there are any questions. And we're good. All right, so let me share our screen and finish up the remaining slides. As I present the remaining slides, I want to remind everyone that this film is also the film of the day within our 31 Nights of Halloween didactic. So along with everyone this afternoon, having watched this film as part of this seminar, there are several of my students that have watched along and have provided comments that they will post on our Reddit thread. When they do, they will tweet that. Please follow us on Twitter. I think I already put that up in the chat room. If not, let me know. I'd be more than happy to do that again. And it'll take you directly to our Reddit community, and you can then comment on my medical students' post about what Hocus Pocus is really about. Here again is the Witch's Brew. And I think an understanding, and this is me again nerding out, of what this movie is really about may actually be hidden in this witch's cauldron. I took the time, it took me about 5 seconds, to actually remove all the ingredients and list them here for you. If you actually take the first letter of those ingredients, the longest word that you can make from those letters is PHOTS, P-H-O-T-S, which just so happens to be a unit of illumination. And I thought that was interesting because this movie has significant symbolism and motif when it comes to light. There's, of course, the lighting of the black candle, that is the black flame shown on the upper left. And there's also the role light plays with regard to the resolution and ending of this film, how to defeat the witches. So I can't dismiss this connection with light and how the longest word you can make out of the first letters as an anagram is PHOTS, P-H-O-T-S, which just so happens to be a unit of illumination. So its relevance in psychiatry, well, it at least allows me to introduce you to the concept of phototherapy, otherwise known as light therapy. Phototherapy is an FDA-approved treatment for major depressive disorder. You should know that there are different subtypes of major depression. We often remember the subtypes, that is, at least in our medical school, according to another acronym, CAMPS, C-A-M-P-S. The S in the acronym stands for seasonal pattern, formerly known as seasonal affective disorder. People afflicted with major depression that has a seasonal pattern are exposed to artificial light for about 10 to 15 minutes per session. We usually initiate phototherapy, that is those sessions, in the fall, as these depressive episodes typically begin in the fall and end in early spring. It is interesting that Hocus Pocus, the film, just so happens to be set at the exact time of year that major depressive disorder with seasonal pattern often starts. The standard output of a light box, we usually have to write a prescription for one to get a light box at a medical supply store. That output from such a box is between 2,500 and 10,000 lux, or about 1 photon. So I just thought it was interesting tying everything together with regard to that witch's brew, a motif in this film, which is light, allowing us to talk about phototherapy and the possibility that along with an eating disorder spectrum, there is the other comorbidity that we cannot forget, which is major depression, which I did allude to in the morning session, but certainly want to revisit in as much as we can also offer light therapy with regard to perhaps a co-occurring disorder in Hocus Pocus, major depression, more specifically, major depressive disorder, seasonal pattern for which phototherapy is indicated. That completes our discussion today. Again, I will briefly stop sharing our screen, and in the 5 or so minutes we have left, take any questions. Nothing? Well, with no questions, I want to bid everyone a good evening, a good afternoon, certainly a happy Halloween. If I don't speak to you before now in the 31st, and again, an invitation to please join us on in our Reddit community and please comment. I do look at the comments with regard to what the psychological or psychiatric perspectives of all of these films are. Again, today's film is by design Hocus Pocus. So visit us on Reddit, certainly follow us on Twitter, and have a happy Halloween, everybody.
Thank you.
Thank you.
Thank you so much, Anthony. Just so everyone knows, I did email out your evaluations. So you'll find them in your email. Please complete them. And then as soon as I receive them back, I can work on your certificate and I'll email those out within 1 week.
You may get encrypted from my email that you'll have to put a password in.
Okay.
Okay. All right.
Okay. Thank you.
All right.
Thanks, Ricky.
Yeah, thank you. Nice to see you.
Thanks, bye.
Bye.